Okay. Bridget Underdahl,
Present.
David Messer, Michelle Tinkler, Michelle Bruchette. Join late. Okay. All right. Okay. We are all set.
Okay, with attendance being done, we're going to go ahead and approve the March minutes. Hopefully everybody had a chance to look at those. Do we have a motion to approve the minutes? First of all, does anyone have any issues with the minutes from March? Okay. Do we have a motion to approve them?
I move to approve.
Okay. Minutes approved. All right, we are going to move into our roundtable section of the discussion. Before we do, I wanted to take a moment just to talk about an uncomfortable topic. So if y'all can indulge me in that. One of our tasks as a group here is to advise on the adequacy of services and to identify barriers and gaps that exist in our system. The truth of the matter is that in order for that to happen, sometimes we have to talk about hard things. Sometimes where there are gaps and people, in the process of identifying gaps, when people encounter them, there's trauma that can happen that impacts a person's ability to talk about it. It impacts the way they deliver their talking about it. And so I just want to honor that everyone who comes here with lived experience has a valuable perspective that we need and want to hear. We can't fix what we don't know about, and lived experience comes with trauma a lot of times. And so we want to give space for people to present their truth and their viewpoint and be able to bring their perspectives that help us identify those barriers and gaps, even when the vehicle that it comes in might not be what we want to hear. We want to make space for truths to be told and for people's voices to be heard. I will tell you, when I started coming to this group, some of you know, I used to dress different. I came here feeling like I needed to prove something, like I needed to be good enough to be in the room. So I would dress my best, and I always kind of felt not good enough to be here. And as my role in the co-chair position here, I just want to model that everyone here is good enough. You don't have to dress a certain way or be a certain way. You don't have to say things a certain way. Your voice matters. So those of you that are online, you can't see me, but I'm wearing holy jeans today. I got on my grace, gratitude, and grit t-shirt. So everyone here is welcome. We want to hear your voice. With that, there's some important things we need to do to create that space where people can feel comfortable and safe sharing their truth. So I want us as a group to establish some coping norms for our conversations. One of them is that we need to assume the best intent of everyone who's speaking in the moment they're speaking. We have no way of seeing what traumas have gone into the perspective being shared in any given moment. And so we want to assume that every person who's speaking is giving the best they have in that moment with what they have in that moment. Number two, we need to be respectful, and our listening needs to be for the purpose of understanding, not so that we can respond. I know as myself, I can be guilty of that sometimes. Sometimes I'm guilty of listening just so I can form the next sentence I want to say. And I really want us to each strive to not do that. Let's listen with the intent of understanding who's speaking. And then the other thing that I wanted to say is I want to give everyone in this group the freedom to cope in a moment where we might feel triggered by something someone says. and to acknowledge that we're all human beings, and frankly, we all get triggered sometimes. And so to give space for that to happen, the truth of the matter is that to make meaningful change, we have to have uncomfortable conversations, and for uncomfortable conversations to produce change, they have to move forward even when they're uncomfortable. So I want us to practice being comfortable saying, you know, if we start to see that in any time in any of our meetings that a topic is obviously moving past information sharing and into a more abusive space, that we can pause, we can take a 10-minute break, everyone can go to the bathroom, we can all practice whatever coping skill we use that works for us, and then we come back to the table and we keep talking about it. Our hope is that we can find, we're not going to always agree at the end of every discussion, and that's okay. Our hope is that we can find enough understanding that we can develop common ground that's a place we can plant seeds of change. So with that, let's move into the council roundtable. I'll go ahead and start. My name's Rochelle Madigan. I'm from Moses Lake. I sit on a bunch of different advisory groups, including this one. I'm the co-chair for this group along with Josh here next to me. I just came from a 2-day Children's Behavioral Health Summit over in Pasco. It was incredible. I was side by side with a bunch of peers and parents advocating for better services for children. It was a fantastic time, and I came away from it really excited about a lot of work that's being done around children's behavioral health that's being led by people with lived experience. And that is kind of fueling the kind of monologue I just gave, because something that's incredible to me about the community of parent advocates is during this last 2-day training I looked around the room and there was like 100 people in the room, and they all were completely diverse. There was different races represented, different backgrounds, different, genders. It was an incredibly diverse group of people, and something that just continues to strike me about that community is when you get them all in the same room together, none of those differences matter in the moment. Their shared humanity and their desire to make a difference in the lives of children is more important than being right about the differences. And so I want us to learn from that and work with that foundational assumption so that we can make a meaningful impact, because these parents are making some big waves in our state, and it's powerful and it's inspiring. So that's what I have. Josh?
That's a tough act to follow. So thank you very much for that, Rochelle, and I wholeheartedly agree with you. I'd like for us to be able to have civil discourse, because I think that's important. But in any case, I'm Joshua Wallace, and I'm a person with lived experience in mental health and addiction, and also a family peer. I'm the CEO of Peer Washington, and also co-chair of the Behavioral Health Advisory Council. So I think for announcements for us, and this is not necessarily ours, but Peerpocalypse is next week. I don't know if anybody's going to that, but super excited. It's Alternatives was always the largest one, but I think Peerpocalypse is kind of, we're going to take that over, and happens right over in Seaside, Oregon. And then also DBHR has the Say It Out Loud conference happening on May 22nd in Spokane, so excited about that as well. In terms of Peer Washington, we are in the process of launching a new site, which I'm not ready to announce yet, but there's a little teaser for you.
My name's Susan Kidd, and lived experience with heroin addiction. As far as announcements goes, one of the things I do is volunteer at Recovery Cafe in Seattle, and one of the things that we've started there, just to let people know, is Smart Recovery meetings. I got my training as a Smart Recovery facilitator, and it's a great thing to have in a recovery setting. So if you're interested, check it out. Kind of an alternative to AA. And then the other thing that I am working on starting at Recovery Cafe is it's a personal challenge, I guess you would call it, is to get more services for trauma. One thing I've found is in being in this space for all these years is I think it's one of the most undertreated conditions out there for substance abuse and mental health issues. So, and it's a complicated issue. I know it's not easy to treat, but That's not stopping me, so anyway, thanks.
Well, good morning. I'm on your list here as a guest. I'm David Dickinson. I'm the Regional Director for the Substance Abuse Mental Health Services Administration, or SAMHSA, which I'm sure all of you have heard of. Pretty sure you have. I also noticed up on the screen, I had forwarded the invitation to this meeting to my Assistant Regional Director, Lois Gilmore, so I see that she's dialed in. So just wanted to let you know and hope that was okay with you all. I thought it would be good for her to listen in at least, and look forward to the conversation and to talking with you about sort of the role and responsibilities, what's in statute for planning and advisory councils, or call it here in Washington State, the Behavioral Health Advisory Council. Share a little history. I had a chance to meet with a few of you by Zoom. I think it was the end of February, and the meeting, and so that was just a precursor to this, and so it's an opportunity to have broader discussion, hopefully, and just a learning space. So thank you for having me.
Good morning, Crystal Eshelman. I work with Carillon Behavioral Health. We used to be called Beacon Health Options. We just changed our name in March. And I oversee our federal block grant funds for North Central, Southwest, and Pierce County. And then I also work really closely with our community engagement team, who convenes the local behavioral health advisory boards in those regions, and our FISBERT, and the Community Partners Committee, which is they review cases for CLIP. And in terms of kind of what's going on, updates with us, we've been working a lot on our block grant plans for next year, and have really engaged the advisory boards in that work this year, which has been great. We also recently did an RFP for assisted outpatient treatment in Southwest and North Central, which is exciting to potentially get those programs up and running in those regions.
Hello, I'm Tessa Clements. I'm the Behavioral Health Program Lead for the Administrative Office of the Courts. I consider myself somewhat of a liaison between the courts and the behavioral health system. Crystal mentioned AOT, and one of the things that we're working on heavily is supporting HCA and the regional AOT coordinators in messaging and communicating with judges about AOT, because they're really undereducated about AOT since it's not been widely used. So that's the type of work that we do, is kind of connecting the dots. One of the updates that we have is in this last legislative session, there was $20 million appropriated to support therapeutic courts at the limited jurisdiction level, so district and municipal courts. And so we are working rigorously on creating a plan so that district and municipal courts can address criminal behavior due to substance use disorder and serious mental illness in a more trauma-informed way.
Nelson Rascone. I am the Executive Director of Dad's Move. I also have lived experience having raised 3 children that all have complex developmental or mental health disorders, and also, oh gosh, I lost count, probably about 5 members, including my mother, that had significant mental health challenges. So I've lived it my whole life. I was also at the same summit with Rochelle. Wonderful event was. I have a lot of updates, but I'll keep it short. Our organization has gone through explosive growth in the last year. We just hired our 20th staff member. It's been a change for me because I'm not really doing direct services anymore as a peer. I'm now coordinating and training the new staff, which is great. I'm passing on my experience to others. So that's kind of been exciting. And then we just put in a slew of funding proposals that if they come through, we may triple our staff again by September. So my fingers are crossed.
Hi, my name's Michelle.
Yeah,
Hi, my name is Michelle Dinkler with the Office of Behavioral Health Advocacy. I'm a person with lived experience, and I don't know how to explain this, but it's like my kids and I, we broke the barrier with our culture because it was behavioral health and mental health was like denial. So yeah, so my mom's thing was clean if you're feeling down and depressed, but I'm the one that gave my kids a voice, so, and I'm battling my family trying to do that. But anyways, the Office of Behavioral Advocacy, we have developed a forum for each region. So anybody's able to log in, and it just gives a safe place for people to express their needs and what's going on in their community. And that's about it.
Good morning. My name is Jolie Ramsey. I'm here representing the Washington State Rehabilitation Council, which is a council that's situated within Division of Vocational Rehab, helping adults with disabilities find and maintain employment. And we are the voice of the DVR customer. So that's the hat that I wear today. And my direct experience, I guess the lens that I bring to this table is my experience working in behavioral health as a member of infant toddler mental health teams. I did that work for several years, just helping children. I worked with birth to 5 children in the foster care system, whether they were in a in-home placement, kinship placement, teaching and helping their caregivers learn about child development and trauma-informed care. So that's the direct experience that I can bring to this table in the mental health space. Thanks.
I can introduce myself. My name is Tori McDermott Hale. I am the Block Grant Data Report Specialist within DBHR. Hi everyone, I'm Janet Cornell and I'm the Federal Block Grant Administrator, so I oversee all of the block grants within DBHR. And just an update, we're in the middle of working on our application for this year. It's due September 1st to SAMHSA, so we're well underway with that and excited to share that at the July meeting.
Good morning, Kimberly Wright. I'm the Behavioral Health Operations and Planning Supervisor for DBHR. And I guess my update is that Governor Inslee just announced a special session. So that special session will start May 16th and last hopefully not longer than 30 days.
Fingers crossed. Well, that special session won't last longer than 30 days.
Hey, good morning. Tisha Kirschbaum with the Division of Behavioral Health and Recovery. I am one of 2 deputy directors, and my purview is over our treatment and recovery programs. Michael Langer is going to be joining us in person as soon as he can.
Thank you. Hey, everybody. Wow, I'm shouting. My name is Carrie Waterland, and I am our Director of the Division of Behavioral Health and Recovery at the Healthcare Authority. And you'll hear more from us during the Director's Dialogue, and I think you'll notice I continue to scoop up folks and bring them with me to the Director's Dialogue, hopefully so that we can get a more well-rounded kind of conversation and an ability to really drill down into topics by bringing Tisha and Michael, who I'm going to say is going to sit right here, along for the conversation. And I believe that Michael is, he's late today because he is leaning in on some of the conversations we have around the opioid settlement. Is that right? Yeah. So he may have something to update us on when he gets back to as part of the Director's Dialogue from that front. So excited, love the music, love the more music. And who do I give this to next?
Okay, and then for sake of time, we'll go ahead and do members updates first, and then if we do have time, we'll open it up to guests. Robert, do you have anything?
No updates for the group. I'm Robert Hopkins, the Behavioral Health Administrator, SUD, co-occurring disorder for DCYFJR.
Okay, give me one moment. Kylan, do you have any updates? Kylan Lynch?
Hi, everybody. I'm Kylan, CEO of Youth Buddies, and currently at this time, there's no updates. I've been out due to medical for some time. However, I am back and excited to learn what's going on. So thank you for having me back.
Welcome back. Vanessa, do you have any updates?
No, and glad to be here. Thank you.
And then Sean Brannon is going to, he said he was joining us a little later. Ruth, do you have any updates?
This is Ruth Leonard. No, I work for Healthcare Authority, supervisor for the Behavioral Health Administrative Service Organization and Contracts, and I don't really have any updates at this time. Thank you, though.
Bridget, do you have any updates?
Hi, Bridget Underdahl. I'm the Mental Health Systems Program Lead at OSPI. I oversee Project Aware grant funding through SAMHSA. And I guess just a reminder of the continued work we're doing. We're building school-based mental and behavioral health systems with our grantees. So more than just using the funding to increase number of counselors and social workers, which is obviously vital, we're thinking about how does a systems design help build what all students need, and so that tier 3 one-on-one services are not overwhelmed. And we're also doing a lot of work around organizational wellness. How do adults also work in this system of care and get their needs met? We know that the workplace of adults is the learning space of students, so really prioritizing every individual within a school system throughout our work. So just happy to be here with you today.
Thank you so much. And then Michelle Bruchette, I think she's also joining a little later. Were there any members that I missed that would like to give an update? Okay, we do have a little bit of time. Do you want to open? Okay, we'll go ahead and do roundtable for guests. Nancy, I see you raised your hand. You're welcome to go.
I just wanted to share an update. I'm retired and I'm involved with a number of extended family members who have had problems with opioids and meth. So that's kind of my lived experience focus area. And when I first got really involved, my step granddaughter had hung herself. And I don't mention that to be shocking, but it did get my attention. And
Nancy,
yeah,
I'm gonna just ask you to please be mindful of triggers for folks. So if you could avoid using specific language that might trigger people, that would be super helpful. Thank you so much.
Okay, I will. So what I wanted to say in terms of an update though, and maybe I shouldn't be explicit, but in my extended family, there has been another death. And I hope that's not too much of a trigger. But I just wanted to say that in connection with this recent disturbing incident that we've been living through, we found that the person had a backpack with receipts showing that they'd spent the last $40,000 from their retirement account before they passed away in a casino. And I know that eventually mental health is going to be fully integrated with problem gambling. And so I'm only sharing this not to be, rude, but I just want to say that, we know a lot about heroin and meth and the mortality issues, but I don't often hear people talk about problem gambling. And I'm just saying it because it's for real. It's actually happening. And I'm here living it. Just wanted to say that. Thank you. Thank you
so much, Nancy. Appreciate that. And you're so right. And problem gambling is underrepresented. And I'm quite sure that Roxanne Waldron, if she could hear that, she would be grateful for your representation. So thank you. What other guests do we have?
Are there any elected representatives who would like to introduce themselves?
Hi, thank you for the opportunity. This is Lisa Callan. I represent the 5th Legislative District and just wanted to join and listen in. I co-chair along with Carrie Waterland the Children Youth Behavioral Health Work Group for the state and serve in the Human Services Early Learning Committee, Education K-12 Committee, and the Capital Committee, where I'm working hard to make sure we've got our behavioral health investments moving through. And so I'm here to do deep listening. So thank you for letting me do that.
Thank you so much for being here. We're really blessed by your presence. Thank you.
Lois Gilmore, would you like to do an introduction?
Good morning, everyone. I'm Lois Gilmore. I am the Assistant Regional Administrator for SAMHSA in Region 10, and I work with David Dickinson.
Thanks, Lois. Thanks for being here.
All right. Carolyn Cox, do you have any updates?
No, not right now.
Thanks for coming, Carolyn. Always a pleasure to see you.
Good to see you too.
And is there anyone else that I missed that would like to give an update or introduction?
Good morning. This is Mary O'Brien. I'm the clinical service director here at Yakima Valley Farm Worker Clinic and Behavioral Health. I was part of the council in the past. Currently, when I'm not doing my day job, I'm helping with co-teaching, again, our new workforce out at Heritage, part of a program of expanding social workers and clinicians in our area. So thank you for continuing to invite me. Thank you.
Thanks for coming, Mary. So good to see your face.
Thank you.
Okay, well, thank you so much, everybody, for introducing yourselves and for being here with us today. I'm going to go ahead and give the floor over. We have a presentation. We're so thankful for David Dickinson for coming today from SAMHSA to talk about all things related to SAMHSA and I think to help us develop some understanding of the origins and purpose for this group. So I'm really excited. Thanks for being here, David.
Thank you. What I think I'll do is, Nathan, you put it up on the screen, and then Nathan also printed out these slides, so you've got them as a reference. How does this work? Does this stick in here? Squeeze it in. I don't know. Can you hear me?
Oh, yeah.
Yeah, okay. Fumble around here. So first of all, let me say thanks to all of you, members of the council. I think especially, Josh and Rochelle, instrumental, I think, in inviting me. I think Kimberly was also a conversation we had end of last year, and we were talking a little bit, and I said, well, I hadn't been to the Behavioral Health Advisory Council in a while, and probably don't know anybody anymore who's on the council, which is pretty amazing. But I don't know, I guess a couple things, just questions up front before we kind of get into the presentation. Is it fair to assume that everybody knows what SAMHSA is? Okay. Okay. Yeah, because I have spoken in audiences before where no one has ever heard of SAMHSA. So it stands for the Substance Abuse and Mental Health Services Administration. And we are an agency of the Department of Health and Human Services and the federal government. So Health and Human Services has Medicaid, Medicare, CMS, Health Resources Services Administration, commonly known as HRSA, Indian Health Services, IHS, Administration for Children and Families, ACF, and many other organizations. Probably the one that everybody knows is CDC. If you didn't know it, you knew it after COVID, right? And then I don't know, also, sometimes when I go to speak at places, they've asked me for a bio or something like that. And of course, there's an official bio on the SAMHSA website, which is kind of lengthy. But I'll just say that I was one of Carrie's predecessors. And I probably have, depending upon who you talk to, the dubious distinction of having been the director when we merged the old Division of Alcohol and Substance Abuse, DASA, with the old Mental Health Division when we were at DSHS. That was over a decade ago. It's about 13 years, 14 years, a long time ago, I don't know. And Carrie was working for DSHS back at that time, as I recall. Oh, well, that's very kind of you, Carrie, because like I always say, it's kind of the dubious distinction, because if you all remember back in 2008, 2009, 2010, we were in the Great Recession. There were many special sessions, but they were about cutting budgets and reducing services. And so we had the difficult task not only of merging the two divisions, which a lot of people weren't happy about, and but also trying to keep enough resources to have services in our communities. And it was really a tough time, and I'm grateful that Carrie and the folks at DBHR now have much more resources than we had in that time. Also, just a little aside, there was so much controversy back then around the term behavioral health. People who were working in what we call addiction sin versus substance use disorders, they didn't want to be taken over by mental health. And people who were working in mental health didn't necessarily want to, work with people who had addictions. And so I polled our staff and I polled people at community meetings, what should we call this new division? And I got lots of suggestions, and I kept suggesting them to the Secretary Dreyfus at that time at DSHS. And she kept shooting them down, and she kept saying, I want behavioral health in the name. I want behavioral health in the name. So finally, after about 6 shoot downs, I said, okay, you want behavioral health. A lot of people in the community don't want behavioral health. I see that we're moving towards integration of care, integration of language. If we go with that, what I want in the title is recovery, because there's no wrong door to recovery. And it doesn't really matter if you've got substance use disorders, mental health issues, or both, or other complicated issues in your life. No wrong door to recovery. So she agreed to that. So that's why we have DBHR, and I'm grateful for that. Grateful for all of you. I'm grateful for the agency and the work that they do. It's hard work. You all know that. I'm a person with my own lived experience, long journey into recovery. And I won't elaborate on that except to say you all know what that means. And it does involve, and I thank you for mentioning trauma, because it does involve trauma. And so many of us in this room have experienced that prior to or during our own journeys through our path to recovery. So I was recruited to SAMHSA from the position at DBHR. And it was when SAMHSA decided to create regional offices. All the other components of HHS had regional offices. CMS, HRSA, ACF, all had regional offices. There had not been a regional office for SAMHSA since its inception in 1992. So 19 years later, 2011, our administrator at SAMHSA decided she wanted to put regional offices. And she did that because of a couple of things. The Affordable Care Act, which included essential benefits for behavioral health, both substance use disorders and mental health disorders as a requirement of the Affordable Care Act. And also because in her experience and in a lot of our experience, it was really clear to us that you can't really separate the head from the rest of the body. You can't really separate the psyche and the emotions from the physical body, and that we needed a holistic approach to health, and that the only real health was health that included behavioral health. So she got the secretary at HHS to agree to that, and we created regional offices in the 10 HHS regional regions across the country, and I think there's a slide that I put in towards the end of the deck that shows that. At any rate, I've been in this position now since December of 2011, and for the first 8 years, I was an office of one. And I served the states of Alaska, Idaho, Oregon, Washington, and our 272 federally recognized tribes. We have almost half of the federally recognized tribes in Region 10. And when I got that portfolio, my eyes popped. I was like, 225 tribes in Alaska, man, that's like 4 people's jobs for like 4 lifetimes. How can I ever do that? But I'm still here. And as evidenced here, I actually now have a compatriot, Lois, the Assistant Regional Director, who joined us in the pandemic, early in the pandemic. She hired on and joined me in 2020. And we're looking to expand the office in the next year or two. So all of that being said, let me ask you, you've got in front of you, this copy of the slides. It's a kind of a lengthy slide deck. It's really an orientation slide deck. It covers really all the basics. It covers the history, the origins, the purpose. I included in there the statute and the statutory guidance. I know from my conversation with Josh and Rochelle and a few of you back at the end of February that there was an interest in kind of knowing more about the purpose and the statutory underpinnings of the council, what we used to call and still call by statute the Mental Health Planning and Advisory Council. And a few years ago, and it's in the slides here too, when our administrator Pam Hyde was moving us towards this behavioral health construct, she said that folks in the states who were applying for the block grants were encouraged to merge these two entities if they had a substance use advisory council with their mental health planning and advisory council. And so therefore, and I think we first initiated this, again, when I was the director back in about 2010, maybe? I don't remember. Carrie might remember the year. So tell me what would be helpful to you all. Do you want me to kind of walk you through the slides? I see a nod over there, because I don't know how much anybody knows, and I don't want to be redundant, but I'm happy to do that. And I'm seeing another nod over here. Okay.
So I think one thing we would definitely want to make sure that we put some time on is better understanding our role in how we work with DBHR. If we want to be the most effective partners that we can have some time on that, that would be amazing.
Yeah, and Josh, I was definitely cognizant of that from our previous conversation, and there's some slides in here that really outline that more. So let's see, Nathan, can you advance that slide there? And we'll have it up on the screen, and you guys have it in front of you also. So the history, goes all the way back to 1963 when President Kennedy got the Congress to pass the Community Mental Health Act. And then that evolved about 20 years later into the block grant, which used to be overseen by the National Institutes of Mental Health, NIMH, which is another one of our sister agencies in HHS, as a part of the bigger National Institutes of Health. And probably you've heard of NIMH. You've probably also heard of the National Institute for Drug Abuse, NIDA. They're both sister agencies. And then in the 80s and early 90s, there was legislation to really build on community systems of care. And then our predecessor before SAMHSA was this organization called ADAMHA. And you look at ADAMHA and you probably get the acronym there: Alcohol, Drug Abuse, Mental Health Administration, ADAMHA. That was the predecessor. And ADAMHA actually did have regional offices in all the HHS regions. Somehow or another in the authorization of SAMHSA in '92, those went away. So there was never a behavioral health voice or presence at the federal level in the regions until we got here in 2011. And I share that with you because I feel like one of my roles, and I outlined this when we were first coming on and we were kind of defining ourselves because nobody had ever done this before, and there were 10 of us, one for each region. I said, yeah, it's great and wonderful that I get to promote SAMHSA's policies and programs, funding, and opportunities like that, our resources, our publications. But you know what? For the past 20 years, and I came from the clinical field. I worked as a clinician for 30 years before I got into state government. So I trained as a psychologist and a registered addiction specialist. So for those 20 years before SAMHSA, all the policy decisions, all the formulation, all the funding announcements, everything was developed out of the Beltway in Washington, D.C. And from my point of view, having been born in Texas and grown up in Kansas, lived on the West Coast since 1984, served in California, Oregon, Washington, running programs, I'm like, you know what? My role is not only to promote everything that SAMHSA has, but to carry back to SAMHSA at the headquarters level, what's the reality on the ground? If you've never been west of the Mississippi River, how do you know what it's like? West of the Rockies, how about Alaska? No road system, go everywhere by boat or plane, essentially, for the largest part of Alaska. Indian country, it's a whole different world, right? So I felt like that was a part of my role, and that's also, one of the reasons that I feel the advisory council is so important, because you help inform block grant application. This state, which has 29 federally recognized tribes, which has a large expanse of rural America on the east side of the Cascades, which has a highly diverse population. And, and what you say flows through that application and review process, through your interactions with DBHR, right on up to SAMHSA, and of course it flows through me as well. So, so that's just a little history. You know that if you go to the next slide, that the grants are formula grants. So they're based on three main components: population, the cost of service delivery in any particular state, and what the state's fiscal capacity is. So some states are small and have smaller budgets, and some states are larger and have larger budgets. Generally speaking, the larger the state, the greater the population, the more your block grant is. And you can see the appropriation for FY22 there, not quite $1 billion, $857 million for the mental health block grant that goes to all of our 50 states. And then you see right in the next slide, the description of the mental health block grant. It is supporting community-based mental health services for individuals with serious mental illness or who are have seriously emotionally disturbed children. So it's really SMI adults, SED children, and that's the intent of the funding. It can supplement services that are paid for by Medicaid, Medicare, and also private insurance. And you all know, I think, really what the block grant is. And there's also technical assistance that comes with the block grant to help states with their applications. and with the implementation of the block grant. SAMHSA administers the block grant. They're awarded annually. Our friends here at DBHR and you all know the arduous process of filling out the application electronically every year. And one of your jobs as the advisory council is the reviewing of that application and then also providing feedback back to the state on its implementation. Yes, ma'am.
Application itself. Looking at the actual application, we found it hard to review, and instead what we focused on is really the things that are going into the application, the projects that they're going to be working on. Is that what you recommend?
I think that that's a smart approach.
Okay, good.
Yeah. Just focusing on, I mean, there's a lot of minutia and a lot of detail, but if you're really looking at the programs that DBHR intends to implement and fund, that's an important way to focus. So you'll see in the, let's go jump the next slide, 2 slides up. I already mentioned that one. Planning Council involvement is required. And then there's definitions for the folks who can be served by block grant funds, mental health block grant funds, both with SMI or SED. So there's the definitional description of where the state needs to target these resources. And I don't think probably anyone has too many questions about that. I mean, the distinction is essentially children and adults. And then it does have some exclusions, you know, developmental disabilities are not included unless a child has co-occurring SED. And on the SMI side, it doesn't include Alzheimer's disease, dementia. And it also doesn't include substance use disorder unless there's a co-occurring SMI. So that's an interesting bit of the language. And we know that going back to what I was talking about in terms of integration of healthcare services and behavioral health, we know by the data, when I was at DBHR, we looked at the data. I've looked at the data across multiple states. About 50% of the people who present for treatment at any given time, in any given year, through whichever door they walk through, have co-occurring disorders. So it really means that a lot of our folks who are doing substance use disorder treatment are also eligible to receive and benefit from mental health block grant funds if they're also, you know, delivering mental health services because it's co-occurring. Next slide. You can see this is just a total package for you of our current funding level by year, FY21, FY22, and the thing that's, I think, worthy of note here is to see how much the funding has been increasing over the last several years during COVID. Congress, and that includes the COVID supplemental funding, $1.6 billion. I mean, that's like more than twice our annual budget, but prior to COVID for the mental health block grant. The American Rescue Plan funding, the Safer Communities Act, I mean, a significant influx of funding. And I think there's been a recognition in Congress, and this has to be, at least in part, due to, I hope, your voices and your advocacy, whether it's locally, whether it's in the state legislature, whether it's up through your congressional contacts, to say, look, we have a higher prevalence of suicide. We have a higher prevalence of trauma as a result of people being isolated. And we have a higher prevalence of loneliness. Did you see the Surgeon General's announcement yesterday? That is phenomenal. He's talking about an epidemic of loneliness and laying out a plan for us to address that. Carrie?
So we'll touch on it a bit more in the director's briefing. I'm really glad that David brought it up. The Surgeon General sent out an advisory, and so there is going to be. I will send it to Nathan. It went out to all of our staff yesterday, and I've actually got it open to talk you through a couple of stats that were found about really the public health epidemic that is loneliness and social isolation. And just really interested in, I think, engaging in all of you with the conversation of that and what's needed to combat that versus serious and persistent mental illness, serious emotional disturbance, and how we sometimes do ourselves a disservice by lumping them all together. Right, and not the federal government. I mean, when we, just the general public, talk about this. So I was really pleased. We're going to get that information out to you. There's also a fact sheet and something else that's attached to it as well. So there's going to be 3 things that come to this team. Yeah, awesome. Please talk a little bit more about it, though.
Okay, thanks, Carrie. No, I'm glad you're bringing it up. I think where I'm tying it in is that it acknowledges another recognition of this current administration, the Biden-Harris administration's really serious and intentional focus on addressing the nation's mental health. And every time we have these conversations, we take another step towards breaking down the stigma and making it possible for people to talk openly and to be willing to seek the help that they need. I think another component of that is the launch of the 988 line last summer and the development in our states of a real crucial crisis management system. So I won't get into all of that. I could spend a whole hour talking about 988. But maybe we'll get to that in discussion or in Carrie's remarks as well. Let's move up a slide. And you see the criteria for the block grant: comprehensive community-based mental health service epidemiology, making sure you deliver children's services, targeted services to rural and homeless populations, and having management systems for all of that. And then states are required to do what we call MOE, or maintenance of effort. That means that there has to be some equivalency between the federal dollars that are invested and what the state is investing on a consistent basis. In other words, they can't take federal dollars and reduce the amount that the states are spending. And we're lucky in Washington State that we've had strong advocacy for many years for substance use and mental health. And our state, except for the period of the recession, our state has not been reducing, but has in fact been increasing resources for mental health and substance use disorders. So maintenance of effort, good. There's a children's set aside. Specifically, there's a requirement for you all, the Planning Council. There's a requirement that there's public comment, and I think that DBHR still posts the application, if I'm correct, on the website so that people have an opportunity to comment. If not, that's something you might want to consider. Or you could do that in other ways. You could have listening sessions, public meetings for public comment. And with the tribes, I used to do a tribal consultation with the 29 tribes to garner their input because the tribes are sovereign nations, and so there's a little different relationship. You're all familiar with the Centennial Accord here in Washington State. For us as federal agency, we have a federal trust obligation that's embedded in treaty, presidential declarations, and in statute. So there's a 10% set aside for early treatment of SMI and SED, first episode psychosis in particular. And then more recently added a 5% set aside out of the block grant for crisis services, which I think is going to add additional resource and support to the state's build out of the crisis system that we're looking forward to. Next slide. And then this next slide talks about in section 1916 restrictions. I think one more up, Nathan. Not moving. I think it would be slide 9 if you can get to slide 9. Oh, yeah, there it is. Yep, 1916. So this is the restrictions, and probably one of the key things is states cannot use the block grant to provide inpatient hospital services. And that's why we have this real distinction between state mental health facilities like Western State Hospital versus the community-based. Block grant has always been designed to facilitate and support community-based mental health. So your community mental health centers, and now potentially CCBHCs, the Certified Community Behavioral Health Clinics. Yeah.
I'm so excited to be able to ask you this question. I'm like a little kid right now.
And don't get too excited because I may not have the answer.
It's okay if you don't. So along those lines, can block grant funds be used to provide services in inpatient hospital settings that are not part of what that inpatient hospital setting offers? I'm thinking of peer services specifically in Children's Mental Health Hospital as I'm asking this question, because it's very needed, especially as we talk about transitioning people back into community. And it isn't part of the service offered in an inpatient setting, but it needs to be. And so I'm thinking of how can we fund it?
Yeah, that's a great question. And you're kind of really getting into the weeds with that question. So I would say, just off the top, that if you have services for children with serious emotional disorders, SED, who have had psychiatric hospitalization, if I understood you correctly, and you're thinking about having some kind of peer-supported service that could be funded by the block grant, if it was not directly affiliated with the hospital, meaning under the hospital's ownership or management, but it was an adjunct to services that could be offered to families and to those children, that would probably meet muster, but the final decision would be made by the grant project officer, who's going to have all the specific details that outline. A lot of this has to do with, we don't pay to purchase or improve land. We don't buy facilities and that sort of thing. But when you get down to inpatient psychiatric services versus peer services, you're looking at two different components along the continuum of care. And I think that the deciding point, at least if I was sitting in that role, but again, I don't have the book in front of me as a project officer, but if the peer, let's say it's a peer organization, it could be a statewide or a local or community-based organization that wants to work in an adjunct relationship and is not owned or operated by the hospital itself, and so the hospital itself is not receiving directly mental health block grant funds, I think that might pass muster. And so it's worth asking and taking that question, I think, to the project officer. Obviously, it's something to talk about with DBHR as you think about your application, because it might be something that, that DBHR wants to put into their application, say we'd like to fund more peer services in the state for youth. Yeah.
It sounds a lot like the Peer Bridger program that we have for adults that's funded by block grants already. So might be interesting to.
I do remember the Peer Bridger program. So that's a good example. Thank you for calling that out, because I didn't think of that, but that may be the model that you want to look at. So let's see, go to the next slide. The planning and reporting. So the Planning Council, the state agrees to make it available to you in terms of planning and review. and also for the annual reporting on the previous fiscal year. And the state has to plan and submit their applications no later than September 1. You already heard that, I think, during the round robin there earlier. Next slide. So SMHA means State Mental Health Authority. Well, we have these funny terms. We have the Single State Authority, or SSA, for substance use. That's Michael Langer's role. Carrie is your Single State Authority for the State Mental Health Authority. Back in the day, I didn't have the luxury of having a deputy or two. I was both the commissioner and the director. Anyway, so the grants, as you all know, come to the state. All the states receive them. The state can delegate their responsibility to subcontractors, subrecipients. There's always a state planner. We have a state planner in the room with us here. Their obligation to work with, for us to make sure that you're working with your planning and advisory council, that the applications are submitted on time, reporting is done, the statute is complied with, that there's quality assurance, that there's some methodology for reviewing the quality of services that the block grant is purchasing and delivering to citizens of our state and the community. And then, of course, there's data collection. And that's everybody's fun thing, data collection. Then we get into the specifics here. The Section 300X3, State Mental Health Planning Council. The state will establish and maintain a state mental health planning council. That is you all, the Behavioral Health Advisory Council, to review the plans of the state and submit to the state any recommendations for any modifications that you might recommend, to serve as an advocate for adults with SMI, children with SED, and other individuals with mental illness or emotional problems. So you can expand the frame. The dollars can't be spent for outside of SMI and SED, but your ability to advocate can certainly encompass the full range of any person who may be experiencing mental issues, mental difficulties or emotional difficulties. And then the third bullet there, to monitor, review, and evaluate, not less than once each year. This is slide 12, by the way, if you're looking at your paper. And what you're monitoring for is the allocation of those funds and the adequacy of the service network. Back in the day in this state, we used to have regional service networks, RSNs. Those have morphed, as you all know, over the years. And so we have different regional organizations now that are responsible for that. You have an obligation, as you look at the network of providers that are part of those organizations, as you look at the providers who are part of the state's Apple Health Plan, any providers that are delivering mental health services, you can look at, you can submit your review back into the state. So those are kind of your three key responsibilities. The next slide is just a visual depiction of that.
Can I ask a quick question?
Oh, yeah.
So what I hear you saying is that there are areas that are excluded from block grants, but in the advocacy portion of our role as a council, we can advocate for things even that are outside of the scope of that, what is fundable. So my question is, when we do advocate outside the scope of what is fundable, what happens with those recommendations, which we know are not fundable by federal block grant? Like what happens, is there a process by which the information gets funneled into the pathway that is the fundable pathway?
That's a good question. So when I think of advocacy, I think broadly. I think not just your advocacy to Carrie and the DBHR staff, but to the state legislature, to local mental health authorities, to your county commission, wherever you live, wherever you're from. You could do that collectively or you can do that individually. So, so I think of advocacy in that sense as very broad. If you are advocating for something, let's say a service that you know by statute is not fundable because it's not SMI or SED, So you might talk about it with DBHR. You know they can't put it into their plan for funding, but simultaneously, you know who the allies are and also who your electeds are, who may not be overt allies of behavioral health in the legislature, but you can advocate to them through phone calls, through personal visits during the legislative session. You can do the same with county commissions, and you can say, what about these services? They can't be funded by the block grant. Can they be funded by another stream? The other good thing I would say, and Carrie can dispute this if you want or affirm it, is that when we started moving down this path of integration in the state, there was a big feud in Governor Gregoire's administration about where should behavioral health sit, DSHS or Healthcare Authority, after Healthcare Authority was created in 2010 when the Affordable Care Act was passed. It finally went to DSHS, and we got moved into the Disability Administration at DSHS, and they didn't really know anything about our book of business. Legislature finally saw wisdom and created the legislation to move DBHR back into Healthcare Authority. That's a good thing when we think about funding, because the vast amount of mental health funding is covered by Medicaid. It's vastly larger than what we can cover with the community mental health block grants. In fact, historically, SAMHSA's budget has been about 2/3 SUD and 1/3 mental health, both in the block grant and in the discretionary portfolio. And the reason for that was Congress recognized, because Medicaid was created 2 years after the community mental health block grant, and lots of mental health services were included as eligible, and they're wrapped into the state plans for Medicaid. So Congress recognized that, and also recognized that there had been an exclusion to funding SUD services. So that's why SAMHSA has always had more money for substance use disorder than mental health, because we knew that the vast majority of mental health services, even at the community level, were fundable and billable through Medicaid. So having DBHR sitting in HCA, which is also the state Medicaid agency, means you also have a direct conduit as the planning council to the voices inside HCA, which are all of your partners here from DBHR, in terms of how HCA is doing their approaches to integrated care, all of that. You can go beyond that in terms of your advocacy to legislatures, to county commissions, to city councils, and say, these are things that we see that are needed. Maybe we want to address the issue of homelessness, and people who have mental illness, but maybe don't qualify as seriously mentally ill. How can we do that? And so, yes, you can advocate those things.
I have another question on the monitor and review, the not less than once a year. We would love to have any best practice information you might have on that. Right now, I think mainly what we rely on to fulfill that responsibility is the peer reviews.
Right.
But we've always thought that just barely touches on things. So we don't have to talk about it now, but any best practice.
Absolutely. And there's a couple slides as we go down the presentation where I'll introduce a few best practices from other states as well. That hopefully will give you guys some ideas to think about and consider for future action. Okay, let's all stretch. I used to teach yoga in a psychiatric hospital. So way back in the day. We couldn't call it yoga though. It was so far back in the day that I had to, in order to get it passed and permitted in the hospital, I had to describe it as relaxation training and exercise. So anyway, let's see. So you kind of just see the connection there. Thank you, God. The next one. So this is just another kind of summary of what I just said. Review and comment on the applications. Monitor the progress on goals and indicators across the system of care, and review and comment on the state's reports back to SAMHSA. Um, If you go to slide 15, you see a little picture of the WebBegas, our web, I love that name. I've always loved that name, WebBegas. the Web Block Grant Application and Reporting System. So it's the online portal where the block grant applications go in and where the reporting goes in. And I think you'll see, and when I get to the best practices, how some of the states are allowing, providing the password or the key to access members of the Planning Council to the WebBegas, and you guys may already be doing that here. So you look at the history and purpose, go to slide 16. Public Law 99669 established the federal requirements for the planning councils in 1986. So that was actually even before SAMHSA was established, if you think about that. We were established in 1992. So it was ADAMHA back then. But the planning, the requirements were included at that time, and then there were additional statutes that are numbered there, and that the states and jurisdiction have to satisfy the mental health planning requirements to receive mental health block grant funds. So you go to 17, you'll see what I mentioned earlier about even though the council requirements are specifically to a mental health planning and advisory council, we encouraged SAMHSA, and this was when I was still at the state, and I want to say it was about 2010, might have been 2011, when, I think it was 2010. Pam Hyde was our administrator. She was the one who'd gone to the secretary and said, we want regional offices for SAMHSA. That was also as we were pushing towards a recognition of the importance of holistic care, whole person care, integrated care. And so we encouraged the merging, which we started again when I was the director that led to the BHAC. And then you go to slide 18, and it gives, in again, that statute 300X-3, the requirements to the states for establishing and maintaining the planning council. And then it talks about, again, those critical steps that I mentioned before: reviewing the plans, advocating for folks with SMI and SED, monitor and reviewing and evaluating not less than once each year the allocation and adequacy of the services. And then you get into council membership, and you guys are probably familiar with, so you have to be a resident of the state for the state that's receiving the block grant. There are also representatives from state agencies for mental health, education, voc rehab, criminal justice, housing, social services, and Medicaid. Representatives from public and private entities, representatives from adults with serious mental illness who are receiving or have received mental health services. So we talk about lived experience, and I would go further to say living experience, because it's not as if we lived it and it just went away. Recovery is this journey that we live, and we live with it. And so I'm increasingly using the term living experience, because we're still living it, folks. And anybody that survived the past 3 years in this country in COVID, you're living it, right? Whether you recognize it or not, we all have living experience. And then, of course, families of adults or children with SED. You have to have enough parents to provide adequate representation for those families with SED, and not less than 50% of the members of the council have to be individuals who are not state employees or providers of mental health services. So, yes, yeah.
So we've stumbled a little bit on what the kind of the vision is for how independent do you want the planning council to be from DBHR? I mean, we saw that, you know, a fair amount of people want to be employees. Of that an intent, or was that never really talked about?
No, that is an intent.
Okay.
It's actually a requirement.
Okay.
you know, when I was, before I was the state director here, I had been the state director in Kansas, and where we had moved back for family reasons for about 3 years. And that was when I made the shift from clinical services into government. And that was one of the first things I learned with our Mental Health Planning Advisory Council was that we had to have, even if it was just by a figure of one, you know, if there was 50 people on the Planning and Advisory Council, at least 26 of them had to be representatives from the community and not state employees. If it was 40, it had to be 21 and 19. You know, you had to have at least one more, if that, okay? And that's a definitional requirement. So, and it's in statute 300X3. So, if you go to the membership composition, since we're on membership, there's a couple slides on that. Slide 19, you can have representatives from the state agencies, public and private entities. I mean, all the stuff that I've already mentioned, folks with SMI, SED, family members. And then here's what I was just saying under slide 20, membership composition. The majority of council membership cannot be state or jurisdictional employees or providers. So it's a combination of state employees and providers that makes up that slightly less than 50% membership of the council. You have to have, yeah, Nathan.
Oh, I just wanted to do a quick time check
Yep.
To let you know.
Yeah.
And because I also know that the council wanted an opportunity to discuss maybe specific questions too, but just wanted to do a quick time check.
Yeah, thank you. Well, we got about 5 minutes, I guess, or something like that. But
well, and maybe we can put this out there. You know, it's a rare pleasure to get to have you here, and so I would. Okay. Okay. Yeah. So my suggestion, if nobody is opposed, is we want to continue with David until, you know, we are done with that, and then we can take a quick 10-minute break and then see what we can fit in time for your presentation.
Can we just go ahead and ask all the general membership, is everyone okay with that? If anybody has opposition to that, could you please say so, either if you're in the room out loud or if you're online in the chat, please, before we move forward? Is everybody okay with that? Okay. All right, thanks, guys.
thank you for bringing it. I don't always watch the clock, and I try, but like I said at the beginning, I was saying it's kind of a long presentation, and there's a lot of slides, and there's a lot of details, especially when you get into the statute and trying to answer questions as we go along too. So, but I appreciate the opportunity. I mean, this is the first time, you know, since before COVID that I've met in person. I haven't even seen Carrie and Michael in person. I think I saw Michael at a meeting in Colorado last year for the first time in 3 years. You know, we were at a rural mental health conference in Colorado, and so it's just wonderful that we can actually come together and be in person. The other piece of this is that I know that a lot of DBHR staff are new since the time that I served here, and so this is also a learning opportunity for DBHR staff as well around the block grant. So hopefully it's beneficial all the way around. So thanks.
Quick question. This is super helpful. So one of the things also with our local behavioral health advisory board that we've struggled with on the composition is the role of peers that are employed as peers, but also really have, you know, lived living and have, you know, recently helped people through the system or use the system, and just thinking like they're technically providers of behavioral health services, but also that living categorize that.
Yeah, that's a really good question, because it's a fine line. And at what point, you know, do we cross the line? Excuse me, I should get by the mic. At what point do we cross the line between being a person who is a person with living experience, who's a peer, who is a recovery coach, who is an advocate, but then becomes employed. And we've worked hard in this state and many of our states to develop systems to certify recovery coaches and peer counseling. So that's you know, I don't know if it's possible for people to make a distinction in their membership, like at the regional level or even at the state level, to say, well, today I'm wearing this hat. Today I'm a representative of the peer community and the community at large. I'm not going to talk about this from the angle of my provider, if that makes sense. Again, I think if it comes to the Behavioral Health Advisory Council, this may be a question to consult with the project officer on, just to make sure that that if you had folks who were serving in both roles, they were a peer, they were an advocate, they were on the council, but now they're employed by a community mental health center or CCBHC to deliver peer services, is that okay? And so it's a really technical question, and it may come down to just whether the person who is serving that role can step outside of their role as an employee and live, you know, in the hat of I'm a peer. That would mean sort of strictly self-monitoring. I'm not talking about my agency. Make sense? Yeah. So. Great. Perfect. So you're already. That's excellent. So there you go. So that might be something that helps you at the regional level too, at a regional council, to just say right up front, who do you represent? And that way people have a choice, and it's all clear and it's all transparent right from the jump. So if you go to slide 21, excuse me, you see the required state agency representatives, and I think we have a few of those here in the room or online. I noticed OSPI. I was glad to hear OSPI was here with the project manager from Project Aware, another SAMHSA-funded grant. And then you can also have representation from the Child Welfare Agency. What do we call it now in this state? DCFS? DCYF, yeah, okay. Used to be the Children's Administration when it was the DSHS. Or from the area agencies on aging and so forth. So those, but you see the required ones, and that has to be part of your membership. Slide 22 is just a reiteration.
Let me ask you a quick question.
Go ahead, Josh.
So I think in COVID really, I think did a lot of harm to our attendance anyway, but with these required like state representation, I don't know that we necessarily have these folks all the time, nor do I don't think we have, well, I don't know what control we have over that. I mean, any other member we have in our bylaws that we can remove, but because these are ex officio positions, I don't know how we maintain that participation.
So that maintenance of participation is incumbent upon the state agency. So the State Mental Health Authority needs to recruit, and they all have relationships and liaisons with, whether it's the Attorney General's Office for Justice, whether it's Voc Rehab, you know, whether it's OSPI for education. DSHS would be cover social services. You know, we have a state housing authority. That's a critical team member for the advisory council, particularly with the homeless or unhoused populations that we serve. And Medicaid is already sort of automatic in a way here because you have DBHR as a part of the state Medicaid agency, but you could also ask for, you know, somebody specific from the state Medicaid agency, but you can ask then. That's the State Mental Health Authority's responsibility to engage those partners and make sure that they're participating. Yeah, yeah. So if you go to slide 23, it's important to document how you review the application and reports, how they were shared with the council. The state has an obligation to do that in their reporting. And then the council chair can verify that and you have co-chairs, so I guess both of you would need to sign off on that, Rochelle and Josh. If you can, sign off on a letter to verify that the council reviewed the application and the annual reporting from DBHR to SAMHSA. And if you have comments, then you can make those comments. And it says here, what we're seeking is really substantial comments. It's not just sort of a stamp of approval. It's like, do we suggest this? Do we recommend this? Or, we suggested to DBHR that we'd like to have these services considered, and yes, they did include them, and we're really pleased about that. So it can really, you can spread the line in terms of your comments, and I think the important thing is just your honesty about your understanding of what's happening. You may have a view of how the services are delivered, how the services are allocated that you want to comment, and that's an important piece. And so it's not just a letter of support. You are, the Behavioral Health Advisory Council is an integral part of the state's application and review process. I can't emphasize that enough. And I know you meet regularly, and so again, there's ways to do this, and that's what I wanted to kind of know. You asked about best practices, and I should say, the next slide, if we go to number 24, before I talk a little bit about best practices, you see these two blocks, what's the role of and what's not the role. So it should be ongoing communication with the state. It should be reporting on the council's views about priorities and needs. And you need to be able to clearly demonstrate that you've been involved in the process of the block grant plan and review. It's not to be the approver. SAMHSA is the approver. So the block grant makes recommendations, makes suggestions. You make your comments, pro, con, yes, no, we think this is good. That maybe could be strengthened. But the Planning Council is not the approver of the block grant. The state's going to submit what they submit. SAMHSA is going to approve it or not approve it.
So does the state submit our letter with the application?
Yes.
Yeah.
Yep. And this is another important thing. It's not just a formality, just like it's not a letter of recommendation. This is more than a formality of like, Josh and Rochelle signed a letter and it's good. It really means engaging in a thoughtful process, and it really means taking some time to think about the plan, to review the plan, to think about, talk with community members, and that's where we kind of get into some of the best practice ideas, so that you can have some substantial, some significant, some meaningful comments that you share with the state and ultimately with SAMHSA. And then clearly, in your letter, you'll demonstrate, that you have been involved in the planning. So if we go to, if you go to slide 25, it kind of gets to what I was talking about. It's a year-long process. That's why you guys meet. Are you meeting quarterly? How frequent? Every other month. Great. That's even better. Every 2 months, because it is an ongoing process, and sometimes things change. Sometimes things, COVID was a big change, for example. Legislative changes can be another example. Changes in the federal administration can be another example. So things that you want to take into account of, if you're meeting more frequently, you can do that. You're working with your state planner, and you want to be really strategic in your thinking. The state receives X amount of dollars on an annual basis through the block grant. How do we want to target those funds most strategically? How do we get the best bang out of the buck that's being spent in the state of Washington for SMI and SED? in Kansas, and I don't know if you do this here or not, we used to use subcommittees to do more in-depth work. And Josh is nodding, so I guess you do have subcommittees to work on different areas. And then as you get new members, having some training for those new members so that they can learn some of the things that we're talking about today. And I've heard, I don't know this, so don't quote me on this, it's not official yet, so this is off the record, but I've heard that SAMHSA may be developing a specific technical assistance package for planning councils. If that happens, I'll let you know as soon as I know. I just heard about it last week, so it may just be in planning stages, but just the fact that SAMHSA is thinking, hey, we need to do this because it's another way to be helpful to the states. So go to slide 26. Here's some best practice examples. New Jersey releases the citizen's password to the web BGAS so that all members can facilitate the reviews to the draft block grant application. Georgia posts a copy of the application on their website, which is what I think we used to do at DBHR, but I don't know if we still do. Or it might be on HCA website. Is that what? Michael's nodding, so we still post. Okay. And likewise, that's probably true also for the substance abuse block grant. Kentucky, this is another thing I was kind of referencing earlier, they held an annual public forum before a regularly scheduled council meeting, and they gather comments there. So that's a way to have you could do that because we're a spread out state. You might think about, hey, you know, we've got members from Spokane or from Yakima or from Bellingham or from those regions. You might want to do regional forums. And again, you have to think about your time, your planning. But that was something I know that when we started to move towards health homes in this state, we did 4 regional listening sessions around the state to talk about integrated health homes. And that was, as a state, you could model something similar to that as a planning council if you had the resource and sort of the energy and the will to want to do that. I don't know where everybody lives or even if that's a possibility, but that's what Kentucky does. And then they incorporate that feedback. We talked a little bit about advocacy. If you go to slide 27, this is where your partnerships and your alliances, your relationships are really critical. It could be with NAMI. It could be with any other advocacy group. It could be, you know, your elected officials from your district. It could be it's clearly not only with DBHR. They're your partners and your collaborators, but you have to go beyond that. If you can engage with community mental health centers, with mental health associations in the state, all of those can be a part of your alliance that help you advocate. And then there's, in slide 28, advocacy suggestions. Part of that is educating the members of the council on current issues related to mental health in the state, looking at things like I said, letter writing, working with the media, doing educational or social events. It's important to find consensus. So to the extent that, for example, Josh and Rochelle as co-chairs may be spokespeople for the council at large, that there's been consensus achieved in the membership and that you are speaking with one voice when you speak to the public, when you speak to the legislature, when you're saying, this is what we're advocating for and we're really clear about it. You can present information in powerful ways, and one of the most powerful ways that I know of, and I think all of you know this, is telling your story. Telling your story. Testify in the legislature if there's a bill that you want to speak about. Testify at your city council, at your county council. Tell your story. Tell why it's important. That's also part of breaking down stigma. You know, that's putting our voice out there. I've been doing this for a long, long time. I'm gray and it shows. You know, I started working at a psych hospital in 1977, if that tells you anything. I was an undergrad. So breaking down the stigma is still a challenge 45 years later. We still have to work, we still have to advocate, and that's where your voice is so important, whether you're a state employee, whether you're, you know, a peer, whether you're a council member, whether you're a member of the community. And I've already talked about legislative advocacy. And so if you do, I think I have another example of that. There was one of them. Yeah, if you go to slide 29, both in Colorado and in North Dakota, their council in Colorado has a legislative day. And they go en masse to the council and, or to the legislature, and you kind of go around and meet with your legislators from your district and have those meetings. North Dakota, they do a legislative breakfast. And I know that I've attended a legislative dinner in Alaska with the legislature, with the council a few years ago. So different states do different ways. Josh.
We have a question from Nancy Watson, who's online. Go ahead, Nancy.
I think she's on mute. Nancy, I think you're on mute. If you're talking to us, we can't hear you. Nancy, you're still on mute. We can't hear you.
Go ahead and continue, Nancy. If you want to type it in the chat, or if you can figure out.
Okay, it looks like I'm not on mute.
You've got two mics on right now because we're getting a lot of feedback out here. You get. Now try. Yeah, you've got two mics. You got one that's on your computer to mute. Yeah, go ahead.
Nancy, can you type it out in the chat and I can read it out loud? Sorry about that.
While Nancy's typing, I'll continue for a minute here. So in Illinois, the council identified critical funding needs in the public health mental service system, and then privately and through their affiliations developed a mental health summit to lobby for additional funding. So they really invited, they went big. You know, they had a summit and invited partners, agencies, treatment providers, members of the community to advocate. Louisiana did letters to the governor and the Department of Health and Hospitals for open access to medications. Florida, they have a quarterly newsletter they disseminate statewide from the advisory council. I don't know, you guys may already be doing some of these things. So if you go to slide 30, I don't know, is it in the chat yet? Okay, slide 30 is monitor, review, and evaluate. So you look at the allocation of funding, what the adequacy of services is, and you can do, and it's already been mentioned, peer review of organizations and programs. You can also have presentations to the council. You're meeting every 2 months. Invite somebody who's got block grant funding to come and do a 5 or 10 or 15-minute presentation, tell you about the services they're doing. And they could do it online or be with you in person. And then, yeah.
So I'm just wondering, I'm looking at all of this stuff on the best practices of both lists, like, again, like a little kid, super excited and wanting to make plans for the future. Along those lines, how do we go about finding out how much money we have to do this stuff so we know what we can afford to plan?
Need to talk to the agency. You know, every year DBHR does a budget. It's a big document. And you just went through the budget process with the legislature. In the budget, and because of unless they've changed this since I was there, we used to have distinct funding streams for mental health and substance use. even though we've integrated, we still have two different budget buckets. So in the mental health budget bucket, the agency has to outline, what's going to be state funds, what's block grant funds, et cetera, and there's a budget line for the planning council. So you want to check with Carrie and Michael and the team over here to see what's your resources.
And then Nancy has responded here, and it's not a question, it's a statement, but she says, I just wanted to thank you so much for highlighting the issue of shame and how it has evolved over the years from mental health versus addiction to what I see now in behavioral health versus gambling problems. Your perspective is truly heartening.
Oh, thank you, Nancy. I really appreciate those comments. It's been my life's work, and it's not just because of what I've lived, but it's just been my life's work, and so thank you. Appreciate your comment. Thank you. Kind of makes me choke up a little bit. So I was on slide 30, monitoring. We were just talking about that. I think you guys know the basics on that, and then whatever pathway you do use to monitor, be sure that you include that in the reporting that goes to SAMHSA, so that the block grant officer, when they're reviewing the reports, can see, oh, this is how Washington's BHAC monitored the block grant. And then peer review is part of that. But again, there's different ways you can do the peer review. Like you could invite providers to come and present to you. There's different components of that you could include in your. And then they have some suggestions from our Center for Mental Health Services that. Let's see. Next slide. Thank you. To recruit members, if you can, who have some data and evaluation experience, either in their personal life, their professional life, and then if you can have and this is maybe something for DBHR to think about, to have a designated liaison from the state that's communicating data on a routine basis, maybe already doing that, so that the council can see and hear the data that you're collecting, and that can be treatment data, it could be other data. So we capture lots of data, and DBHR reports a ton of data through the system up to SAMHSA. So and it's actually better, I think, when you get it closer to the ground. If you're getting data that's from within the state and it reflects what's happening in the communities or counties of the state, that's going to be a lot closer to home, and I think more meaningful for you. And then there's best practices on 32, kind of related to that. The Tennessee Advisory Council initiated a longitudinal study of 95 county jails that led to initiatives in cross-training, jail diversion, and education. Illinois got feedback from a wide range of stakeholders on the key priorities for mental health service delivery. Rhode Island created a subcommittee to investigate the 100% increase in state-funded acute psychiatric hospitalization. That's extraordinary, 100% increase in hospitalization. They published the result with recommendations which are responded to by the Mental Health Division to remedy the problem.
Do you know how or where they published this?
I do not know. I think you could probably, Google Rhode Island mental health and find it there. I found it extraordinary when I read that. Nevada collaborated with their mental health department and did consumer surveys to assess the quality of outpatient services at the community mental health centers. And Oklahoma had their state decision support staff. And I know we used to have decision support staff at DBHR. I don't know if you still call them that, but your data folks at DBHR. But anyway, Oklahoma used those folks to provide the council training on data, indicators, and monitoring. So just other ideas. I think as we look at slide 33, you know, it's really about, and I know you're already thinking about this, is how you move forward. What will the choices be that you make around how you connect with and advocate, how you build alliances, the frequency and the transparency of the communication that you have between and among yourselves and with your state partners. And you know, I mentioned before, you have to continually, if you go to the next slide, you have to continually monitor things that are evolving in the environment, public policy, funding. Nobody anticipated COVID and the impacts of COVID, you know, for all of us. I used to talk about before COVID because in the 4 states that I serve, all 4 states have higher than the national prevalence of suicide. Generally speaking, at least 2 of my states are in the top 10. And with the opioid epidemic, it was only about 4 or 5 years ago that the overdoses from opioids eclipsed the number of suicide deaths in our states and nationally. So I used to talk about a twindemic, a dual epidemic of suicide and opioids in our states, in our region, and of course nationally. And then we had COVID. And so, you know, we had a triple threat. And the residue of COVID and the impacts of COVID has directly impacted the overdose epidemic and suicide. You know, this crisis of loneliness that we mentioned before, depression, isolation, the things that we have been challenged with. The vast majority of people who are dying of overdose, they're not dying on the streets. They're dying in the privacy of their room alone. That's the sad truth. So these are the things that we have to take into account. You all have to think about, you have to consider when you think about the resources that we have. I know my colleagues at DBHR have the same commitment that I have, and I think that all of you have in this room to do this work, to do the best that we can. If you go to slide 35, there's a little resource page there. Just some links for you that can help. There's all the laws and regulations for the block grant. There's a National Alliance for Mental Health organizations that it's an interesting website. It's a more broad, it's not specific to the block grant. And then we have our own resource page. You can also check out the Safer Communities Act and the funding that came through. There's also the statute link. And then I just threw in the next slide, if you go to 36, just a map so you can see that's if you communicate with other advocates nationally, if you work in any organization nationally, and it might not be just for SAMHSA, it might be for HHS in general. Those are the 10 HHS regions, and those are my colleagues in those regions. And you can see where our headquarters are based. You can see all of our linkage. So if you have friends or colleagues, other advocates that you work with, let's say, and they're in Dallas, you could contact them and say, hey, have you talked to Christy Brooks? Because she's the Region 6 SAMHSA administrator. Why don't you invite her over to talk to you down in Texas, you know? And the same is true for any of these. All of these folks I've worked with for a number of years. Some of them, there are 5 of us that are what we call OGs. We were part of the original team back in 2011 when the regional offices were created. That's me, Charlie next to me up there, Jeff next to Charlie. Charlie's in Denver, Region 8. Jeff's in Chicago, Region 5. Gene is in Region 3, Philadelphia, and Dennis is in Region 2, New York. And then the others have come on board as others of our team. Our original team retired. And just as an aside, Kim, who's in Kansas City, worked for me. She was my Medicaid liaison when I was the division director in the state of Kansas. So she's from Kansas too. Now from Missouri. She lives on the Missouri side now. But anyway, just if you have friends or colleagues that you reach out to or that you're in communication with, you know, we have lots of national organizations. It's not just how you advocate here in this state, it's how you advocate in Congress. And I think the effectiveness of the voice of people with living experience and the realities of what the data is telling us is why we have more funding now. SAMHSA's budget since the beginning of the opioid epidemic has tripled. The first big infusion was $1 billion in the Cures Act to address opioids, but you've seen much more funding as I put in the slides earlier. So I think that's all the slides, and I know we've been doing questions all along, so, and my contact information is at the end of the thing. I live here locally because I moved to Olympia when I got hired by DASA. And I was only DASA for a month, and then we merged. When I laugh, it makes me cough. I'm getting over a cold. Excuse me. Anyway, I don't know if we have more time for questions or if you want to shift into Carrie's time, however you want to do it.
David, I just want to say thank you so much. I feel like you have just given us a feast of information, and we're going to be making turkey sandwiches for a long time from this.
All right. Right.
Like, I just can't thank you enough. Josh and I had the privilege of attending a listening session for technical assistance a while back, which was really impactful to me personally because some of the kind of issues that we've been having in recent history and trying to navigate through were the same issues all the other states are having. And so it was really like, oh, we're all kind of like, this is not new. Okay. And what you have just unpacked is pathways by which we can navigate those things and help develop a partnership that can really make a meaningful impact in our communities and in the work that we want to do. So thank you so much.
And I just want to take a moment to just add to that, you know, that meeting was really amazing to be with all of these other co-chairs. And so I hope that something regular could be developed around that so that we could not be working in our own silos, but also be sharing some best practices with the other advisory councils.
Was that listening session, was it national? I mean, did you have folks from the councils from all across the country? And it was convened by CMHS convened that? Great. If you have some information on that you could share with me, particularly which branch at CMA, I mean, I know it's the block grant branch, but it's what division, and I'd like to reach back to them and you know, see if they
These guys actually facilitated it for us, so Nathan would have information for that.
Okay,
but
great.
also, I just wanted to like be brazen and ask, can we get a commitment from you to come here like every couple of years and bring us more turkey to gnaw on?
Absolutely. Happy. Excuse me. Maybe I won't have a cold the next time. But yeah, and you know, as old and gray as I'm getting, if I retire, what I'll do is I'll ask my successor to do the same. It's important. I think you get the gist here from the conversation that we've had. It's so important to have presence. It's not only a legal requirement. It's not only that you are in statute. It's the fact that that you're bringing a voice that has been marginalized far too long in my life, and that has an opportunity, I think now, perhaps greater than ever, an opportunity to really advance the needs and then the resources to meet those needs, our communities, states, and our tribal communities. Glad I've lived long enough to see the changes that have come from way back when I started. Had to call yoga relaxation exercises.
Well, thanks again so much, David. I am going to, we have just about 25 minutes until we're supposed to have lunch. I want to be respectful of the fact that we're all humans. Does anybody need a 5-minute bio break? Okay. Yes, so we're going to take a 5-minute break. That's going to put us back at about 11:41. So we will see you all in about 5 minutes.
My apologies for being so long-winded. Thank you.
Thank you. That developmental disabilities are not included for a child unless they have SED.
Right.
What about for adults?
So
Is it the same?
that's, I think, it doesn't spell that out. Substance use disorder. Because we have lots of people, abilities, adults, also have a serious mental. That's probably a good question to ask. You can do that through the.
Thanks.
Yeah, absolutely. And what's the organization you're with?
I'm with Carol on the one of the behavioral. So for Caroline, we're in North Central and South. And then the other regions, like the
Spelled like C-A-R-I-L-L-O-N.
it's like care lawn, CARE. We just rebranded.
So when you say North Central, we're talking Okanagan?
Okanagan, Chelan, Douglas, and Grant.
Okay.
Because I live in Wenatchee.
Live over in Okanagan? In Wenatchee?
Yeah.
Yeah.
Yeah, I love it.
There's been so much change, as we've moved towards wide managed care and have the managed care entities. Environment that I inherited when I first landed.
For sure, yeah.
First big shifts was, hey, Michael, good to see you, sir. Because state statute. And it was right about the time that I arrived, and so we wrote RFP.
Right.
Yeah, so, and that was a huge deal to have party engaged, managing, but they did good work. Still engaged there, you guys replaced
So
them?
now we've replaced them with AHA. I don't actually know how that happened. I believe I'm with Caroline for a little like a year and a half. So, and they brought me on just originally specifically to manage the federal block grant funds in Missouri Regional. And I've done a lot of research and everything, but it was still great to hear your presentation and like a full complete overview. It's just a lot of digging to find stuff and reading the laws and stuff that they're.
This is a little, I mean, it's still a long presentation, but hopefully it's reasonably digestible. And a couple of the slides are kind of repetitive with a little visual that, you know, this is what we just talked about. But yeah,
it was awesome. And I was thinking a lot too about, because every region has a behavioral health advisory board, right, at regional level. And I was thinking like, how can, because they're struggling with the same issues that the council is, right? And like, how do you provide comments and feedback? And I'm thinking like, how can we kind of integrate that network more so that the boards are connected to the council and understand like the flow of how to advocate.
Are the regional councils, are they mandated as a part of the contracting process?
Yeah. So the ASOs are, it's part of our contract with Health Care Authority to convene.
Well, it's probably a reasonable conversation to have with Carrie and them, because it might be that that you could, you know, make a recommendation that as you seek, you know, new membership.
Guys, we are at 11:41, so we are at actually 42. So we're just past our 5 minutes, and I want to make sure we're giving DBHR some time.
Or just a connection, even if they're not on the board, but like a way to have bi-directional communication, right? Yeah. Because they, the regional ones also review the regional.
All right, we have just a little bit of time left till lunch, so I'm going to hand over the microphone to DBHR leadership, and they're going to do their best to scratch the surface of what they want to tell us and send us the rest in email. Thank you guys so much.
So team, I do see that we are agendized to talk about the peer review recommendations and discuss those, but I also know that we just landed our legislative session, we just did a bill review, and we just heard today that there's going to be a special session. So I don't know what you all want to talk about, but my guess is we may give you updates on the peer review recommendations in writing, and that we may want to discuss the other things. If that's accurate, I'm looking at your nods. Okay, I don't want to talk about things that aren't helpful. So sorry, yeah, I've taken this one.
Does that work for people online? If you are interested in something else, please put it in the chat.
Okay, we don't see any dissent on that, so yeah, let's go ahead and talk about what's current.
All right, perfect. So I am going to do a really, really brief, I think, overview of what legislation and legislative session kind of has given us, and what we anticipate may be happening during special session, and give kind of Tisha and Michael some time to talk about any of the specifics as we kind of go through. So one of the first things I wanted to say is, as usual, right, our legislature was very active in behavioral health, was very committed to continuing to fund programming that is in existence and creative in some of the new work that they wanted us to kind of pursue. So innate in that, just as we, I think, tell you every year, but more so every 2 years, we're still working through a lot of the heavy stuff in the budget right now. And what we can say is, if you've taken a look and a gander at the budget, you want to look at section 215, which is the community behavioral health budget specifically. And Nathan and team, if we haven't already, we can send links out to folks if they want to look at the budget, and just kind of peruse it on your own. But it'll give you, I think, a really good flavor as to why it is that we're still working our way through it. And seeing kind of what gifts were given to us and what challenges we may have to kind of come up against. So that leads me to something that I'm just going to talk in a very, very high level kind of generality is, we have noticed that this year, can you hear me?
Yeah, can I ask you a quick question before you move forward?
No. Of course, Josh.
Love it when you turn me down. just because we've been dealing with some other issues around this, and so what I've come to find out is there's maintenance budget, and then there's of course the past budget. So when we look at the state budget, are we looking at the new funds added, or is the section that if we were to go look at it, does it include the maintenance budget piece?
You know what? Yeah, right. Good question. It's sort of a yes and. Some of the maintenance maybe had made it in as far as it's kind of continuation. Some of it's going to end up in this thing that's called back of the budget that's in the back of the budget, that people who are much smarter than I around kind of budget drafting are able to find. That's where we'll find things like usually where we get full-time equivalent employees listed and that sort of stuff. And then you will see some special programs that you may not actually see that stuff in writing anywhere, but it's continuing on. And so again, it's a yes and to all of that, which is again, why it is so confusing for us to sit down and go over the budget in a short amount of time, team. But I think, kind of to David's point, maybe it's a healthy thing for us to just have as a topic as we come every other month to talk about as we learn more.
Yeah, and I think it's a kind of a good way to not have people come at you when they don't see stuff, if they have a better idea of where the numbers might be if they don't see it.
And this is Tisha. I just have to throw in like the questions that Josh, that you just asked right now, we all asked the exact same one. Like, okay, my gosh, is this in the carry forward? Is this in the maintenance? Did anybody else see it? When are we going to hear from budget?
Totally true. It's totally true. And so maybe it is one of those things that, again, your group, right? But if it would be helpful for us to kind of talk these things through as we sort of continue to unfold. I'm going to mix so many metaphors today, as you all know, and peel away different pieces of the onion. I think we can come and talk with you about it. Yeah, yeah. And as usual, if any of you engage in the programs that we have currently happening and you are concerned if your program that you receive services from or that you provide services for, if you're concerned, shoot us an email and we can look at it for you and let you know if we don't see it or if we're still kind of pouring through it, right? I know Josh, you and I have had a couple email exchanges on things. So just keep that in mind. Our answer may be we don't know yet, but just reach out. Absolutely. The one thing I think I wanted to just really high level talk about is that we did notice that the work that you all do with us on our block grant application and the report to SAMHSA that is approved, that outlines sort of what we in DBHR and Healthcare Authority and you all have talked about needing. There are some different ideas that came from our elected officials. So the legislature has done some things that we'll be, I think, talking with folks about during the interim. There are a little bit, there are some different administrative caps, which are actually driven by the federal government. So we'll be working with our state legislature to understand that. And I think that there are other opportunities for us to continue to work with elected officials and the work that we do with you and just how vetted a lot of this work is as we go through and how we spend our block grants that may be really beneficial for our elected officials to hear. So I say all of that because I think listening to David talk today, knowing that we are all really interested in how do we move this work forward for community behavioral health in the best way, I think we're just in a really great opportunity to open up some conversations about some really complicated stuff, right? Block grants are complicated. Behavioral health is funded in a different way than other healthcare, and yes, so much is covered by Medicaid right? And so if we can help folks know the work that's already being done behind the scenes, it may be really beneficial and helpful. And I think a good use of us being able to engage your voices in advocacy and things that you're seeing that are working as well. As David said, one of the things that this group really has the opportunity and option to do and lean in on. So just wanting to share with that, with folks, kind of that little fact, and that we think there's going to be a lot of opportunity to continue to talk, not just with our elected officials, but with all of you and state government or county government folks and city government folks about like, what are block grants? How do they come in and how are we using them, right? And so we're kind of excited about that. It's going to be a fun little thing that we'll be doing during the interim. I'm going to pause there for a second because that's just a kind of high level, I think, of what we looked at as we were going through the budget and things that we know are directly impacting the work that you all do. Before I move away from that, the other thing that I just wanted to touch on is Nathan will be, if he's not had a chance to already, forwarding an email from all of you on the Surgeon General's advisory that he just sent out. It is, team, I'm not going to take a ton of time on this because you'll have the stuff sent to you, but it's powerful. It is my hope that we drive ourselves toward a conversation in Washington State around what does this say for prevention activities, right? What does this say for what we can do to move the ball way, way closer to the beginning where we can intervene and hopefully have an impact? What does it say when we realize that loneliness, isolation, are, yes, the answer or I guess the problem and the thing that we're trying to solve through recovery, right? Because what is recovery? It's hope, it's connection. And so all of these things to me as I read it, and I'm really looking forward to having you all read it so that we can talk about it, is it connected the fact to me that we say behavioral health, and a lot of times what we mean is emotions, is sadness, is human behavior that yes, we have to address and we have to support. And it's not the same as needing a prescription for psychotropic medication. And so where can we make sure that in behavioral health, we're hitting everything? Because I know that you all are like me, we're all tired of waiting until it's too late. And so I think our legislature has made investments. I'm going to tie it up. I think our legislature has made investments that are challenging us to look at how can we do this work better. And if you can take that in conjunction with what we just have from the Surgeon General team, that's the way that I would love for us to continue to converse and challenge ourselves and not talk about the treatment aspect of things or the crisis aspect of things or the recovery support services aspect of things, but all of them and where we have the gaps. So I'm going to stop. If anybody's got any questions for me, you know, David, maybe it's a job thing. We can both talk forever. And I'd love to, but I wanted to give Michael and Tisha time to talk about any of the specifics that they saw as well. Team, any questions for me? And I'm acutely aware that there's more people in the room than these three that I'm staring at. So I apologize for not kind of, casting my gaze more broadly, but I'm going to pause. Any questions for me before I give it to awesome subject matter experts? Okay. So as you know, Michael was a little bit late talking about some of the opioid work. Michael, do you want to kind of?
Thank you, Carrie, and I'll watch the clock here a little bit also. Carrie's right, obviously with the budget quite complex as it was passed out last week. About $5.1 billion for behavioral health and about 124 individual provisos. So that's a lot to digest and try to work through. And as was already pointed out, there's also resources in the back of the budget that need to be brought forward and so on and so forth. That's about $360 million more than the previous. So while we didn't get everything we'd hoped to get, it continues to grow, and we are appreciative of that. I won't get into the weeds too much on this, but part of the complexity, just to familiarize yourself with a little bit, is that we have the regular state funded budget, right? And then Carrie's talked about the block grants. That's an area that typically we apply for SAMHSA. You guys all see those. We know we've had the extra ones with the pandemic and such. And we have to get those plans approved. And then when the plans are approved, we put them out in contract based on what the plans approved was. The legislature gave us some gifts of resetting stacking the chairs or readjusting the chairs on the deck, so to speak. And so we need to sort through that. If we change what we said we would do, we need to go back and communicate that. And so, yeah, yeah. So, yeah, well, how to be more clear? It's with the regular block grant, we have priorities. And so we can fit things in those priorities pretty well. You guys know what they are. We've talked to you about those. And so we don't get into a lot of really finite specifics programmatically. When the CRRSA money came, which was President Trump's last budget during the pandemic time for block grant enhancement, and then when the ARPA money came, President Biden's amount, we had to get a little more detailed on what we were going to do with the money. We were going to do this under prevention, this under recovery, this under treatment, but we had to kind of detail that out. The legislature looked at how we were doing with those, with the regular block grants and the new block grants, and said, okay, but we have some ideas too, and we recognize that you haven't built out or spent all of that, even though it's in contract right now. We are in the process. So they've asked us to do some different things with it. And so we're trying to see where we can line up, and we can do some of that. And Janet here, I don't know if she slept in the last week and a half, but we could see where we can come into alignment. We may not have to go to David and his colleagues and ask much, but there are some areas we probably will. And so then we have to go through the process and get that approved. And then what might that mean? It could mean that some existing contractors are getting less because we've had to reposition over here. Now we also have to take into consideration underspend, and maybe maybe those reductions won't be so significant, but that's all some of the back work that's happening right now. In addition to the block grant, we also had the opiate settlement funds, which we talked to you all, that went through a process and we prioritized, and the governor put in his budget and the Senate concurred with. The House had a little bit different idea of what we should do. But the conference budget in the end had some way different ideas of what should happen with that opiate settlement money. And so that's something we're having to consider also is we want to get monies out quickly, right? We want to get them out near to July 1st as we can, if we don't have to go to bid and procurements. But with this change in the last week, we have to look and see, okay, now how are we able to do this? Some of those dollars, some of those opiate settlement dollars, were also tied into the Blake bill that did not pass. So for example, the administrative dollars associated with being able to operationalize the opiate settlement dollars is tied into the Blake bill. So what do we think is going to happen? Special session, Blake bill passes, we'll have access, we'll have to then decipher and see how much of the changing of the deck chairs we have. But that's when very simple questions are asked, like what did you get in the budget? That's when we kind of stymie a little bit and say, we think this or we think that. So that's really it. It's our job, I think, is to try to bring this to you in the clearest way possible, and we're still trying to add clarity ourselves. So just a little bit of context there, and I think that might. The last thing I'd say, I touched on it for a moment, but we are in contracting mode now. So as soon as session ends, how quickly can we get money out? And that's what, while Janet's trying to figure out how many nickels and dimes are where, the rest of the division is really spending long hours right now trying to get contract language negotiated so we can get it out by July 1st. And mostly we're successful, but not always. And there will be some after the facts, and we know that, but we try to keep those to a minimum. But if you want to know where our energy is right now, it's trying to decipher the budget, get contracts out, and then, believe it or not, start thinking about agency request legislation and building the governor's supplemental budget package that he'll put out next December. But I think I'll stop since we are 1 minute. Oh, it said 1 minute.
No, we're good. All right. So that's Michael's good news, everyone. If you have a little bit more you want to share, I think.
No, that's
right.
Okay, yeah.
We technically have.
You have questions? I mean.
Hi, everyone. Tisha. My updates are really quick. Then we can answer any questions that people have. I believe, Nancy, I believe it was at the beginning when you were giving your update, you were talking about problem gambling and how gambling has really affected one of your loved members' lives. It made me think, hey, I want to give an update on a bill that actually passed this legislative session that is connected to problem gambling. So it's called 5634. It passed. It's actually getting signed by the governor tomorrow. And really what that does is how problem gambling services are funded right now is through a portion of a tax, and that goes into the problem gambling fund. So what this bill did is it allows us to pull down a larger proportion of that tax, which means that the money that we have to fund problem gambling services will increase. So that was a big part of 5634. The other part of 5634 of this problem gambling bill is that it really put an additional focus not just on treatment, but also on prevention. So the other part, just wanted to call that out. The other part I wanted to mention about problem gambling services, and please, Michael, Carey, anyone correct me if I get this wrong, we are working towards making problem gambling a Medicaid reimbursable service. So, yay! That won't. I mean, not all people have Medicaid, so that doesn't help with everyone. But it does, for the people who do, it does open up a very large and stable funding source to be able to address this issue. So, just some information I wanted to make sure that people were aware of. The other bit of information is just not quite as fun news. It's about the public health emergency unwind. So this is a really great example of one of the benefits of the Division of Behavioral Health and Recovery being part of the Healthcare Authority. The Healthcare Authority has a massive work group that is working on the public health unwind, specifically how it's going to affect Medicaid, people who have Apple Health or Medicaid. So and the reason we're calling this the public health unwind is one of the things that happened during the public health emergency is that people, now I'm going to get the word wrong, so please everyone just bear with me here. When you're on Medicaid or on Apple Health, they tend to review to make sure that you still qualify. And often what makes you eligible or qualify is about income amounts. Redetermination, that's the word I was trying to think of. So during the public health emergency, the Healthcare Authority stopped doing those. Well, now as part of the public health unwinding, we have to go back to doing that, which means that there's a lot of individuals who didn't have to worry about, will I still have Medicaid? Will I still have health insurance? Can I start this treatment and not have to worry about that at some point, I'm no longer going to have my health insurance. So there's a lot of really horrendous things that happened in the past 3 years, but I think not having to worry about that particular thing was a real weight off a lot of people's shoulders. Unfortunately, that is getting rolled back. And so one of the things that they're looking at the Healthcare Authority is, one, how do we do it? How do we send out all those notifications? How do we try to do it in a way that's as least impactful as possible, knowing that it will impact people? And there's only so much control that we have on that. So,
early and often, right? Funny to me when we are doing a blast on social media around a lot of this, right? And like LinkedIn and Facebook and everything else. And it's the same tale as we always have, which is, okay, but we're not reaching everybody. So if there's ideas that you have on how we can get even more information out, right, on what's happening as part of the public health unwind, let us know. And because, right, the most tragic thing that could happen is that somebody is not aware of this and loses their health insurance, isn't unaware of the fact that that didn't need to happen.
Yeah, absolutely. They've actually been doing a huge hiring push at the Healthcare Authority to hire all of those positions. So good question. I am sure it is, and I don't know exactly, but I bet that's something we can find out and get for you. So yeah, great call. Thank you. Yeah, and you will get those calls.
It's kind of funny you asked that a little bit in that we have some positions we're trying to get hired. They're on hold because we need to get enough people in to help with Unwind. So it really is a priority of the agency to get, and they have been. They brought on, like Tisha said, quite a few.
We also are aware, right, that we've got some presentations, so I don't want to take a ton of time. But is questions that we can answer from anybody on your membership?
I think given the fact that we have just like 9 minutes left until our next presentation, I'd really like to give folks an opportunity to grab a bite to eat. So if anybody does have questions, could you please either post them in chat or email them to Nathan, and then leadership can get back. Are you guys okay with that?
Absolutely.
Okay,
Absolutely.
perfect. Go ahead.
So the special session, so is that to address that the Senate bill didn't pass, right?
The Blake bill for, well, I'm sorry, as we all probably have,
Or whatever?
right, yes,
Yeah.
that did not pass during regular session. And so
And you feel confident that something will pass in the special session, or is it just?
we have no way of knowing, but this is what I will say. The special session can last up to 30 days. And I bet, now I haven't been involved in the conversations, but I bet that folks have been talking to each other behind the scenes. And
I would imagine.
Yep, and that we are looking at elected officials who are coming, ready to have a conversation and ready to move something forward. What that may be, I don't think we have a great handle on yet, but what I can say is I know that each and every one of them have been committed to working on stuff behind the scenes, which I think is why we're looking at kind of a mid-May pulling folks into special session. Kim, does that sound accurate kind of with what you've been hearing is folks are ready to talk this through? It's been, I have a massive amount of respect for our elected officials. It is a tough job, and you just won't ever see Carrie Waterland running for an elected office. It's a really, really tough job, and I wish them a lot of luck and support when they go into their special session. Yeah.
All right, with that, grab lunch. Okay, everybody, we are at 12:16 right now, and I want to be respectful of folks that are presenting. Some of you have come in late. I know there was some DBHR leadership and a few other members that have come in late, so I wanted to kind of update you. At the very beginning of the meeting, I gave a little mini monologue about wanting to create a culture within this group that honors diverse perspectives and creates a safe space for lived experience to be shared for the purpose of identifying gaps and barriers that exist in our systems, since that is part of the charge of this group. So toward that end, I had talked about developing some coping norms to be implemented in the middle of these meetings, and a few things that I thought of that would help toward that end. And y'all feel free to add if you have any other good ideas toward this end. But my ideas were to assume the best intent of whoever is speaking, recognizing that we're all humans and we experience emotion. And sometimes where there are gaps and barriers, there's trauma, and trauma can impact the way we deliver our lived experience. So I just want to be honoring of that we're all humans, and assume best intent of those around us who are speaking. In addition to that, we want to be listening with the intent of understanding, not with the intent of responding or reacting. And then the other thing is that I want to give everyone who's present the freedom to acknowledge being triggered in a moment and take space for themselves, step away if they need to, as well as if anyone in the group feels that any point of the conversation is shifting from being functional to being more abusive in nature, we can just say, hey, let's take a 10-minute break and give ourselves space to move through emotions and experience them and bring ourselves back to baseline. And then we're going to come back and continue talking. Because in order for meaningful change to happen, we have to move conversations forward even when they're hard. So I just appreciate everyone's willingness to do that. I'm excited where we're going as a council. I'm excited to have hard conversations that lead to change. And I'm really grateful to have Diana Cockrell here to talk about family-initiated treatment, as well as Peggy Dolane. They will be presenting probably some different viewpoints along the topic of family-initiated treatment, but this is such needed conversation in order to bridge gaps that are existing in this topic. So I just appreciate both of you for being here. And with that, I'm going to give the microphone to Diana.
Thank you. Thank you for having me. Hi, Peggy. It's good to see you again, too. It does go in there. Okay. Sorry for the noise. We'll get this set up.
If everyone would be willing to, could you please, as they're talking, could you please write down your questions? We're going to have a time to answer questions at the end. We'd really like to hear both presentations fully before we address questions and concerns that come up. So please, so you don't forget, write them down in the midst, and we'll just push forward until the end and then address the questions and comments. Thank you so much.
I might just hold this. Let me know if this isn't working. Thank you for having me today. Thank you for the invitation. My name is Diana Cockrell, and I support the prenatal through age 25 behavioral health section in the Division of Behavioral Health and Recovery. So a little context, we think about FIT through the lens of a three-legged stool: systemic, cross layers and levels of care, application, and ongoing stability. To do that, in implementing a policy, we need to consider the point of view of families and youth and providers. Specifically, assuring and supporting that youth without parental support have the ability to access healthcare, and families have support to ensure young people who may not want but need services, that their families have options to access those services for them. And training and supports for providers in increasing high quality engagement and service provisions that look like help to and for young people and for their families. All right, what is FIT? You can see the definition on the board. I will share some examples of the when the bill passed for family-initiated treatment. This came from a stakeholder work group that met about 20 times over the context of a summer that included youth voice, family voice, and provider voice, coming up with a recommendation to move an existing law that had been on the books for a long time called parent-initiated treatment into the new version, which was renamed through that process, family-initiated treatment. And part of that was expanding the definition of parent. So the person that can access services on behalf of their young person is expanded to include a birth or an adoptive parent, a step parent, a kinship caregiver, a DCYF caseworker, another relative who is responsible for the youth's health care decisions, or someone who's given a signed authorization by the parent to make health care decisions for the youth. One of the things that we highlight with this is that youth must meet medical criteria for treatment based on the professional person's initial evaluation, and that medical necessity must be met for family-initiated treatment to be implemented, similar to how if someone was trying to access service and didn't meet access to care or the medical necessity, they wouldn't be allowed to access those services. In the next 4 slides, we're going to go over the different pathways and levels of review one by one. First one we'll look at is the process for outpatient treatment. So you can see it laid out on the board, kind of the process that happens. Medical necessity must be determined by the provider, and then the FIT administration does a separate review of medical necessity every 45 days. FIT allows up to 12 outpatient services in up to 3 months, and the youth must consent to treatment after those 12 sessions to stay with that provider under, it's more like that FIT stay will end if the youth doesn't engage in services and want to continue. It's probably a cleaner way to say that. If the provider is not a match, or if there's still need for outpatient services for that young person, the parent can initiate through FIT with a different outpatient provider. Checking my notes. On the bottom of this slide, you'll see a link that goes to the provider guide that has all of these processes and more information if you are interested. And an early goal with FIT is to engage youth in the services they're receiving and to bring the family or natural supports into that process when safe to do so. We know this reconnection, when safe to do so, provides connection and potential support for continued stabilization of that young person and the family. All right, so then we'll move to the FIT process for more intensive outpatient treatment options. So in addition to traditional outpatient we just looked at, there's also in the books treatment in a less restrictive setting is what you'll see in the law. And what that means is less restrictive than an inpatient setting. Programs like intensive outpatient, partial hospitalization fit in this. The type of outpatient treatment this type of outpatient treatment has a separate review standard for the FIT process. The specific shift or difference is there's no session or time limit. So it doesn't have that so many sessions in so many days box that it needs to fit in. And there's a provider treatment review for medical necessity every 30 days that's required to be documented, and a FIT administration review for medical necessity every 45 days. So those are ongoing, absent of time limits, except for documenting both the provider every 30 days and the FIT administration every 45 days. Next slide. All right, so this is the process for inpatient treatment. The steps in the process are listed on the screen for inpatient treatment. Inpatient process for review has both a provider and a FIT administration review for medical necessity. The provider does that review in the first 24 hours. The FIT administration does their review in a 7 to 14 day range. If the youth still meets medical necessity, admission under FIT can continue in an additional 30 days from the day of that review by the FIT administration. Facilities that fall into this inpatient category, these are some but not all: Seattle Children's Hospital Psychiatry and Behavioral Health Medicine Unit, Smoky Point Behavioral Hospital, Tacoma General Adolescent Behavioral Health Unit, Inland Northwest Behavioral Hospital, Sacred Heart, Kitsap Youth Inpatient Unit, Two Rivers Landing, South Sound Behavioral Health or Hospital. All right, so next slide. This is the process for FIT under residential facilities. The main difference in residential and inpatient processes is that in residential facilities, care is ongoing based on the provider's review of medical necessity, and the FIT administration reviews every 30 days. Currently under Washington law, the facilities that fall under residential are licensed as SUD providers. FIT allows for evaluation of substance use conditions under FIT. SUDs, facilities that have utilized FIT to date include Daybreak Spokane and Excelsior Substance Use Program. A little bit about some of the work that the team is doing to get word out to the world around FIT. We were able recently to secure funding for Spanish translations for HCA FIT training platform. The original committee that did the work of transforming the recommendation to update what we mentioned before, the then parent-initiated treatment, built into the process a survey and feedback loop as part of the recommendation to learn how the new policy was landing in the real world, and if there were policy recommendations we needed to make to get to the goals that the group identified. Not any of us in that room could have imagined the impact of a worldwide pandemic in the middle of that space. The original timeline for that survey had ended a year or two ago, but we requested support from legislators to extend the survey beyond the initial timeline, and are looking forward to virtual and in-person conversations and information sharing for providers on using FIT, and listening sessions with parents and youth to continue to explore real-world impacts, learning and training needs, and using that feedback to inform ongoing education and training opportunities. All right, next slide. A little bit of data around FIT. The numbers that we're looking at on the screen are from January 1st, 2020 to March 31st, 2023. For some clarification, admission means the admission to FIT, meaning the FIT administration received notice from a provider that they had a young person admitted to their care through FIT. And then the review numbers are the number of youth that were in care beyond the 7 to 14 days before a second review of medical necessity was needed, and received that second review to continue care under FIT. For a little context on current use of FIT, so as part of the numbers you're looking at there, we broke out the numbers from January through March. This year, there have been 141 FIT admissions. 87% were for mental health inpatient, 10% were for SUD, and 3% were for outpatient mental health. Thank you. In April of 2021, we were able to stand up an online learning environment for FIT trainings. In the winter of 22, we had the opportunity to roll out a new campaign and work on raising awareness of the online modules when we had the great privilege of bringing our current FIT administrator, Monica, to the FIT team. We continue to see an increase in access to the trainings as our new communications team member and Monica continue working together. Of the 230 some folks who have accessed the online training, about 55% were providers, 15% were parents, 8% identified as student, and 22% as other or no indication. And there's a link to this training in the resources part of this deck if you're interested in checking it out. This is a picture of agencies who have trained personally with Monica in either in person or virtually since July 2022. What we're learning about some of the challenges agencies are having that are impacting their ability to keep folks trained up in FIT policy will probably sound familiar to the room. Staff shortages, new staff in the workforce that aren't as familiar with the legislation, some of the impact of having senior staff leaving the agencies, so that natural mentoring of being in a community of people who are already doing that work is impacted by those things. The team is actively identifying additional stakeholder groups that need training. We would love your insight and invites to groups that you think would benefit from knowing about the FIT option to support families accessing care for their youth. All right, let's go to the next slide. Here is a list of links you can use to explore more as you would like and to share if you would be so kind or as it makes sense. The next slide has the contact information for our experts in family-initiated treatment. And I think the next slide is just a thank you and space for questions that will wait till after both presentations.
Awesome. Thank you so much, Diane. I really appreciate you taking the time to give us that information. Peggy, are you okay with starting a little early in the interest of having robust discussion at the end? You're on mute, my dear.
I know. I was trying to find my microphone. Yes, absolutely. Let's have the conversation and really appreciate the information that Diana presented about where we're at. So you guys have my slides. Obviously, this first one is just getting the slides up for a slideshow. Click on enabling editing and then, yeah, so back up, click and slideshow. So you have to click enable editing so you can get into the slideshow, I think. You see that yellow line that says enable editing? Yeah, do that. And now, and then you should be able to open up the slideshow. Okay, obviously next slide. So why am I presenting? Because I'm a pain in the ass. No, what am I presenting? I'm going to say why I'm presenting. I want to talk a little bit about my perspective of behavioral health and children, just some definitions from the outside and the cultural values and expectations, having the focus primarily on that, because I think that's part of the internal external conflict we're having. And then I have some proposals for improved process that leads into our discussion. So next slide.
Peggy, can you go ahead and tell everybody your name and why this topic is important to you?
Yeah, well, so, okay, go to the next slide. Hi, I'm Peggy Delane, and I am an intersectional parent of 2 special needs children with behavioral health disturbances. We're the first openly gay couple to adopt an infant in the state of Washington, which leads to some of my reluctance to trust the processes that were in place before with at-risk youth, because I don't trust the courts to where I was not even legally able to adopt in some places. We're a mixed race family. We have private insurance, but we used RAP and CORS in King County, so I've got a lot of experience in the system. My family is law enforcement, which is similar to military family with a lot of trauma and some really command and control methods being used by one parent that makes parenting really difficult. I'm elderly, at least according to the COVID people, because I'm over 60, but I am postmenopausal, and as a woman, that's like you're practically non-existent in society. And I'm female, and I have a really strong feeling about how we don't talk about primary caregivers because, my children were raised by 2 women, but one of them was the one that did all the work on the family side, parenting side, as far as all of the navigation. It's not that my ex wasn't parenting, but the navigation of the system falls to the primary caregiver, and our family-based language does not include the reality of the primary caregiver. And as a woman, I think that's a feminist issue. I'm also technically disabled during this process. I learned I'm an autistic, highly capable person, but I'm also gifted, upper middle class, privileged American citizen. And I have so much privilege. It's sometimes people, when I present, have a hard time taking my experience as valid. But again, my children came out of prison when they were born. They were in prison before they were born. And, that makes a big difference. I ended up sending my children out of state because CPS was threatening to take them away from me or using at-risk youth. And I've spent at least 1,000 hours. I'm not, exaggerating of how much time I spent. I went to every single meeting of the committee, and I'm the one that brought the idea to the state in 2016 and spent a lot of time trying to get people to talk honestly to me about what our barriers were, about why we didn't believe in children accessing care other than PIT, which is what it was called before. Okay, next slide. So this presentation is brought to you by countless unpaid volunteer hours, social isolation, burnout. I have been seriously suicidal to the point I can't talk much about it. By the work that I've done in this arena, I'm perceived as racially hostile and difficult. But I have fresh trauma every time I send an email to Healthcare Authority trying to get these issues resolved and keep coming back and keep coming back. I want to say I'm really happy about some major movement that we've made. Diana and Enos and I are going to be meeting about some of these discussions after this. Maybe we won't need them all after this meeting. I don't know. But I definitely bring a lot of trauma to this page because why do I keep thinking about it? Because I keep getting trauma from families who are supporting children who are going to be homeless, or they're overdosing, or they're dropping out, or they're getting put in jail because the spirit of the law doesn't have an advocate within Healthcare Authority. At least that's my perception. Next. So I want to just talk really briefly about what the ages are we're considering. And I, as a child of a 91 and 97-year-old adults who are still alive, that I consider myself a child. And we need to look at the fact that people do exist within a family their entire lives, even if their families are traumatic or have difficulties. But the people that we are talking about here are 0 to 12, and those are minor children. And I just am putting the ages down because this population here are the ones that are turning 13 next year up to 2036. And so it's really sort of important that, like, basically the people who are 13 to 17, a lot of these policies weren't in place. And my children are 22 and 24, and lots of stuff wasn't available. So next slide. And it is 13 to 17. That's what I meant to say. I haven't proofread this, and I don't expect it to be, well, I sort of proofread it, but I don't expect it to be perfect or even correct. So this is the kind of thing, if I'm wrong on stigmas or assumptions, this is my perception. If there are others that I've missed, I think it's important for us to identify. But I really experienced that bad kids have bad parents and mothers exaggerate problems, that I should just wait and see. I mean, being told alive in 25, that should not be a slogan. Just keep them alive till 25. That parents don't do the work, that if a kid's not participating, it's the parent or the child's problem. I mean, there's some problem that is, instead of looking at what's the problem with our system. We see JR as acceptable system alternative. And I've called staff on this within healthcare authority. It's been a few years since I heard someone in the healthcare authority say that getting their child arrested was the best thing that ever happened to them, you know, because that was the only way to get behavioral health care before I joined the advocacy work. But that is not something we should be saying to anybody, that jail is not something that we want our children accessing. And that the idea that children have to engage, I mean, why is this voluntary? But we don't expect children, we don't tell children that school is voluntary. And so our attitudes towards behavioral health seem to be based on adult views as opposed to looking at children within a family. Finally, the last one being no developmental differences that impact a 13-year-old's ability to provide informed consent. This probably is one of the biggest problems that we have, is that we are allowing children with developmental capacities where they're not capable of conformed consent. We're letting them do it. And we haven't figured out a way to help families navigate that when we emphasize that youth consent is the norm and parent and family initiated treatment is an add-on. Next slide. I just wanted to put in a whole bunch of behavioral health interventions for minor children that aren't therapy or WISE, just so that, because I had your attention and I just wanted to do this. So consider this a commercial interruption or disruption or whatever, that, you know, there are so many things that we're not doing in the early arena, 0 to 14. You know, that home-based problem solving isn't happening. You know, friends groups can be somewhat helpful. I mean, some of these things are things that my children use and some aren't. But no more time needing to be spent on this, but I just hope that we can broaden our view of behavioral health in this process, because again, when we keep talking about family initiated treatment as an add-on to like counseling, we're not seeing the broader system of care needs. Next slide. So the culture of how we describe children's behavioral health to me is super important. You know, we've got the family versus the system. You know, the family has the issue at hand that they're trying to solve. And they do that in the context of a religious environment where some religions call things sins. Some religions believe that things will be resolved in the afterlife. You know, some religions don't believe in science, but we have separation of church and state in our country where religious beliefs are valued to be able to be executed. But we have to do that within a social and cultural environment where we have laws and the rule of law that we follow, that we try to pass, you know, that we're trying to use. So that piece is part of the problem here, because we don't have complete science. The medical community has been bringing our system of care out of a military-based hospital system that, you know, that's how the hospital system's developed, and a doctor top-down patriarchal type of system delivery. And it focuses on diagnosis, like what's your problem? What are the, you know, symptoms? And usually that's like give them a medication, do a surgery. You know, what is gender affirming care, for example? Like, people don't even know outside of, you know, hormones and surgery. I know there must be other things than that. But the way we talk about a medical model is really limited. And also that serious mental illnesses typically don't develop in minor children. I have met families that have children with schizophrenia that developed at age like 7, but like that's so rare. But how we respond to children's developmental challenges may create a mental illness like serious anxiety and a substance abuse disorder. Next. So what does the history of the United States have to do with this? Well, it's a trauma history, and our trauma history is how we've developed our rule of law. So the first people that came to this country, the New England settlers, they were coming here from a trauma history. And I know this because I have a very early relative that was a Huguenot that had to flee France when he was being religiously persecuted. And if he didn't convert to Catholicism, he would be made a slave. Really, he fled slavery to come to the New World. And the Calvinists, the Mayflower, the Massachusetts Bay Colony, those were people that were breaking away from top-down patriarchal view, but of the Catholic Church, but they still had a lot of patriarchy involved. The head of the family being the father, and that family was where problems were solved. And anyway, you look forward to like, okay, at the United States, we have the Revolutionary War, no taxation without representation, but we didn't even think about the Bill of Rights for several years afterwards. And then moving forward, we have a lot of trauma of Native Americans. We have King County being established before we've even had a relationship with the Native Americans signed. It wasn't until 1888 that non-property owners, men, had the right to vote. I didn't know that. I mean, look at that. I mean, we're talking about undoing in the behavioral health world a system that has been brought forward and developed by property owning men. Okay, so just moving forward, women started getting included in the equation in 1920. But as we didn't have access to contraception until 1938, that was my mother's generation. And then I want to talk about youth voice because teen voice is, this next section is my lived experience. The Voting Rights Act, the ability, which allowed all people to vote. The loving versus whoever, which is interracial marriage. Earth Day, homosexuality, not a mental illness. Several things around women's rights and access to contraception, and the IDEA, which is the Disability Act for Children's Education, wasn't until 75, and then we got the age of consent in 1985, and then things basically stopped changing until marriage equality. We tried to pass the Equal Rights Amendment in 1972. It started, but we had to, it died. We didn't pass it. So that, again, back to the family and our definition of the family and the role of women in the family, primary caregivers as a lesbian family who had 2 women, there's definitely a difference. These are important things for us to understand in the climate of assumptions that each of us operate within. Next slide. So our children's behavioral health milestones in my lifetime, we developed family system theory back in the 50s, but we're still not applying it in the 21st century. The 60s was when the Community Mental Health Act started. And this is important to notice because it was created because Rose Kennedy was she Down syndrome, or she had some sort of developmental challenge where she could not control her behavior, so they gave her a lobotomy to treat her. And so that's where they were like, institutionalizing people and cutting out their brains is not okay, and we're going to start moving in a different direction. So in the 70s, there was a huge youth movement. We had transactional analysis in school. And then we moved, through birth to 3, starting with the Disability Act in the 80s, adverse childhood experiences. We didn't start funding SUD awareness until the 90s. And I bring this out because the people in the room, how many of you, I can't see into the room, but how much of this room, the people here were born in the 50s versus the 70s versus the 90s? I think sometimes if you were born in the 70s and you didn't experience what it was like to see the Equal Rights Amendment fail as a young woman, maybe that's where some of my intensity comes from. I don't know. Next slide, though. But I wanted to look at youth and young adults, and here's the ages, here's the years they were born. And I put that up there because I want you to think, what year did you start working at the Healthcare Authority? So the children that are under the age of 13 were born between 2011 and 2023. My young adults were born in 1999 and 2001. Next slide. So the policies that we developed during the time that these children, before they turn 13, impacts their ability. So the kids that are turning, so the left-hand slide those are the policies that are the things that happened while my children were in school. So for example, in 2008, the Great Recession cut all school nurses and counselors and art and music and, you know, all that stuff to bare bones, and it never got restored until last year, because special education was never fully funded until this year, you know. And so we look at, you know, McCleary, for the group of kids that are 13 to 17-year-old, McCleary was identified as chronically underfunded during their school time. And it, you know, and we just started funding it again in 2019. So the TR settlement, which is the WISE, that's started in, I don't know, 2007, I guess it was filed. And in 2014, it created FISPERDS, but we had to file a federal lawsuit because it's still not delivering services, in part, I think, because it's voluntary and the population that are being boarded are not capable of providing informed consent. Next slide, because of developmental challenges. So the relevant system of care, and this is, I think, 2 slides, and then we'll go on, is that these are the ones that I thought were worth bringing up to think about and discuss in this conversation. One, I guess I have more because I have to talk about information sharing. That information sharing is not well understood by providers. Attachment disorder and school refusal, there's no treatments. Family is, like I said earlier, is fit as position is sort of an outside process. Like you have to learn about it, as opposed to it's just part of the process. You know, you bring a child in, who's in the room with you? It's not parents requesting treatment. There's a family in the room with you, and there's obviously a parent that can be consenting. It's not a parent requesting treatment. That's just so not family friendly. Policies that cause trauma to families aren't being actively identified. And I know that because of the Family Care Act asked for that, and it was going to cost a lot of money, and there was a lot of resistance to it. We can talk more about that. You know, the lived experience voices haven't been included as policymakers and decision makers. I know you're working toward that, but the input process is really challenging. And that's been part of the process with rolling out FIT. I was really integrated. I mean, I was the visionary that brought this to the legislature. I've been pushing being the family voice. And then for the last 3 years, I'm trying to make sure that policies being implemented as the families that were, you know, family voice was requesting, and it's a one-way conversation. I put emails in and then they produce something, but I don't get to talk about it. Then I have to do another email, and it's really difficult for both sides. Also, our CLIP programs, inpatient or residential. I mean, when Diana just talked about our examples of inpatient versus residential, we didn't mention the CLIP program. And that was part of one of the things that I've been really concerned about the rollout is we couldn't tell our CLIP residential, you know, because I was looking at the 30 days, and the 30 days shows up in the Child Study Treatment Center, but that looks residential to the community. And yet it is not falling within that, I don't think, but it should be. It seems like we have no residential programs other than short-term SUD. But short-term SUD, like Daybreak, is the same as inpatient hospitalization. It's not a long-term residential program where a child is getting school and all kinds of training and retreats and et cetera, and community-based services, which can happen in a residential program. The system of care client rights don't include the right to have a family. I don't even understand why. We don't have the mandatory reporting inhibits behavioral health and families because we're not going to tell you what's going on. Because what I discovered as an autistic person, because I just do I don't realize these things. That's why CPS was going to take my children away, because I was being honest with the therapist. Anyway, next slide. So the qualities of the at-risk children who receive the least support, I think is important to identify. A lot of times I think we're looking out for the quality of the child who is the most reluctant to get help from and have their parent involved. But we really need to understand that, like, when we tell a child who's 13 and adopted that their parent doesn't need to be involved in the decision making, that's a trauma that we're doubling down on for those children. When we don't acknowledge that fetal alcohol spectrum disorder is something that needs more than 3 years of early intervention, that's going to impact their ability to make, with impulsivity and decision making, those are known symptoms, and we treat them like they're every other 13-year-old, that's missing the boat. When we don't understand that the shame-based services within schools that really are punishment focused and don't appropriately interact or intervene with kids who have behavioral problems, those kids end up with severe discipline issues and dropping out and not succeeding in long-term school. Finally, we know about BIPOC kids and non-English speaking kids. And of course, the impoverished children are the ones that can't access the services. I am here because I had that. I reached the CPS line, and then I called my parents and had them help me. They helped fund the care that my children received out of state, and my children are doing really well now. Next. So there's a unaccomplished intent of the RCW, the three-legged stool, that this, I didn't put the entire intent from the RCW, you can look at this, but the intent is that parents are given an opportunity to participate, and it should be integrated in terms of it's part of, it's participating is part of what parents need to do. And the way we design it is still a way of feels, well, my son is in a mentorship to be an SUDP right now at Ryther, and he's been there for a month and a half, and he has not heard of family-initiated treatment or how to have parents consent. So because that's not the way they think about their model. And then providers shall assure that the ability of parents to exercise reasonable, compassionate care and control of their minor children when there's a medical necessity without requirement of filing a petition. And frankly, we know that petitions don't work, and we are not, even when families are seeking help, we're not validating their concerns. Next slide. So information sharing is a perfect example of why I keep fighting about this. And this is, I think, one of the last remaining big issues in the rollout. But the public-facing materials, the Healthcare Authority says, mental health providers are now allowed to communicate if the provider believes blah, 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 okay? Well, next slide. Mental health providers were allowed to be able to share that information before. But if you look at what did House Bill 1874 say about it, this is what it said, in the law that was passed, not how it got written in the RCW interpreted by the lawyers, but the actual law said that a mental health professional is encouraged to exercise discretion to proactively release information and records to assist the parent. And then we specified the 6 different sections, right? When we came to this part of the writing of the law, we found out from the Hospital Association that the parent had the right to the mental health record. The entire mental health record could be requested by the parent at any time under 70.02.240. But for some reason, our system had gotten so far into youth consent that we lost track of the fact that families, a child doesn't have to sign an ROI to give the parent information. And parents are supposed to be, professionals are supposed to be encouraged to proactively release. Now look back at the previous slide, what it said. Are now allowed if, now go 2 forward, 2 slides forward. Wait, oh wait, okay, so go back. All right, I guess that's all I put down was those 2. So what I want to know is, I feel there's a huge disconnect between encouraged to proactively released and of something that they were allowed to do for years before to a statement of they're now allowed if. Okay, next slide. And
Hey, Peggy, are you okay? We have a scheduled break at 1 o'clock, and given that all of us just finished eating lunch, I want to give folks a chance to go to the bathroom. Will it be too disruptive if we take a quick break?
No, I think because I'm moving in Family Care Act, I think I don't remember how many slides I have been pretty, yeah, I only have 2 more slides, so yeah, go ahead.
Okay. If you, are you guys all okay with letting her get through the rest of this? Perfect. Okay, we'll just keep pushing forward and break after. Thanks, Peggy.
Okay, so the Family Care Act was House Senate Bill 5438 this last session. Senator Warnock and Senator Dingra sponsored it. And why it exists is, see that little picture of Shyla? Shyla went to a hospital up in Snohomish County during 2020, and the hospital she had a provider, a parent, and an insurance company saying that treatment was medically necessary for her. But the hospital didn't know how to manage her not wanting it, so they called in a DCR. And the DCR said, oh, this kid's fine, and released her, and then she killed herself. So there was a medical necessity, there was insurance, there was everything except understanding how to use the policy. So it seemed to me in the time that I've been trying to advocate for getting the Healthcare Authority to urgently get this information out and get it out clearly so that even DCRs understand how to use it, because they don't. We thought, why don't we look at a Family Care Act to have the right of a client to have their family involved? Because that, I've seen documentation, the DCYF for older young adults, and I know Jerry Clark, where DCYF excludes families of mentally ill young adults in Western state, even when they want to be involved. That's like problematic, right? So we need to look at these policies that cause trauma. You know, the DCYF will look and pit a child who doesn't want treatment, who's in hospitalized, that needs to come home to systemic care, but there's other children that child's been abusive to, and the family is way too disrupted, and the kid thinks that they can handle it at home, and the rest of the family is really mental health is disturbed by that child, up to the level of being choked to death and having to be resuscitated by a parent. I have an example of that. And CPS will say, we're going to take your children away if you can't take this kid into your home because they don't want treatment and there's no bed for them. And this is just, it's unacceptable policies. It failed in 2021 and reintroduced in 2023. And I think it doesn't necessarily even need to be a bill. It could be something our culture of this group could work on. Next slide. So the last, and this is my last slide, is ideas of ways to be involved in action steps, both for parents and the system and partner, et cetera. So one of the things is like that survey that you guys were doing out there, you know, what is that quality improvement plan for both for FIT and WISE? How do people get involved in it? Like, I couldn't find information about the FIT survey is going on still. If you haven't completed it, it closes May 4th. There's a stakeholder group, but you know, I couldn't find which ones were for families, which ones were for providers, what happens to the information after you gather it. Like, I think families should also be, like the FISPERTs could be part of helping assess what you heard and having discussion and knowing there's a place for us to have our voices being heard, because the FISPERT hasn't been a place where I felt heard. Things tend to go into black holes. Clip beds should be residential. That doesn't need to be something that we pass a law for. That's a decision that's being made internally, I think. I don't know. We could have Healthcare Authority bringing forward recommendations to the Children's Mental Health Work Group about motivational interviewing, or what are the, you know, school refusal. What are the earliest consent issues that come up? You know, if you've got a kid at school refusal and then you're trying to bring them to treatment, of course their treatment refusal. Refusal's their problem. How do you fix that? And then create materials to help parents navigate consent, because a lot of parents don't know how to work with an adolescent, because our culture has been, and a huge portion of our people have religions where the father is the, is the person in charge of the home, and then you have a kid disobeying it, and you come into a culture where the culture's not supporting the family's culture, the healthcare culture. And there's good reasons for that, but we talk about culturally appropriate care, and yet we completely ignore these kinds of issues about how do you help parents navigate the consent process that we think is in the child's best interest. So hopefully I've given you a number of things to think about to try to give you an idea of why I think culture is so important. And just to say that, it's been this really long process of trying to, my goal has been to get the intent of the law, the work that the families and the providers that we all did through all those sessions that summer of 2018. And the things that we decided, like that parents should be getting information, that's a best practice, even though maybe we don't say best practice, but that was well agreed upon in that group, and it's not coming through in the materials that the legal department is presenting. So thank you.
Peggy, thank you so much. I just want to say again, I super appreciate both Diana and Peggy for coming and sharing these perspectives. As I said earlier, we can't fix what we don't know about, and we can't know about things unless people feel comfortable to share their reality and what they know. So I super appreciate both of you for being willing to do that, understanding that there's been a lot of behind the scenes dialogue back and forth between the two of you that hasn't always been the friendliest. So I just know probably both of you came into this feeling some kind of way, and I appreciate both of you for being willing to stand up and speak in spite of those feelings. We're all humans, and we all experience emotions from our trauma, and I think this is a really good modeling of what we need more of, having hard conversations and realizing that we're shared humans before we're different, and coming together to find common ground to bridge gaps that we know we need to bridge. So I just appreciate both of you, and I really hope this is a starting place for more robust discussion on this topic, as well as a good example of the types of discussions we need to have about other topics that have hard things attached to them. So thank you both so much. I want to open it up for questions. Does anyone have questions related to anything that's been presented around family-initiated treatment here?
Weren't you going to take a break?
Yes, actually, that's a good point. Could you write down your question so you don't forget? Let's go ahead and take a break. Yeah, 10 minutes. Yeah. So we'll come back at 1:18. Thanks so much, everybody.
All right, everyone, it's 1:18, so I'd like to call us back together. Crystal, yeah, we do have a question for you, Peggy, when that member gets back. But in the interim, do we want to move now into discussion?
I want to say while we're kind of waiting that the SAMHSA strategic plan includes technical assistance to help do all the work that we are embarking on right now, to include system providers and families and youth, the ability to reform behavioral health care for children across the developmental spectrum were words used, which is super cool because that's part of the issue that I'm bringing forward, is that we have this kind of a more of a one-size-fits-all approach and not understanding that they're kids that in the developmental spectrum can't meet the needs. So thanks for that little commercial, and whatever the question is, I'm happy to entertain it.
I'm glad I'm not the only one that does commercials during my talks.
Hey, if you get a chance to say something to people like those ideas for what is behavioral health that isn't therapy, I'm going to put it out there because I want people to know, right? You guys are important. The people in this room are super important.
That doesn't do you any good, actually. It showed you it just showed you from head to toe.
All right, so I had a couple questions on the fit, and they were for you. Yeah, it was on the slide where you were talking about the number of admissions that you've had, and you did say like the number of inpatient, outpatient, and residential. I was hoping you could just repeat those numbers, and then I was curious about geography of fit admissions, like if they're all in a certain geography or not. And if you had any insight on why the numbers of SUD admissions were so low compared to the mental health.
Let's see. All right. So it's, I don't know if we want to pull the slide up, it's 8. So I think the question was go through the numbers again. Yeah, the ones I said. Okay, perfect. I have those. Let me see. So from January through March of 2023, we've had 141 fit admissions. 87% were for mental health inpatient. 10% were for SUD, and 3% were for outpatient mental health. And the question around geography, I have a list of what I believe is inclusive of the providers that have used, it's not going to be inclusive. I need to follow back up with you on that one. That's a great question. More to come. I have it written down. And then why are the numbers so low for SUD? SUD has the federal confidentiality law that follows what the states, there's more sorting we need to do. What the law allows for with SUD is the evaluation. And so that's my understanding at this point in time, subject to updates, is that the data we have for SUD is for the evaluation. And then beyond that, if they do a really good job with that, they're able to engage that young person and get them in care. But the sharing of information, yes, they have to do it silently because the federal confidentiality law.
Well, Diane, I wonder how much the SUD number is being low just because we're talking about 13 to 17-year-olds.
Many, if not most, of our schools have SUD. Hold on. Yeah. So this is, my name's Tessa. I currently work for the Administrative Office of the COIS as the Behavioral Health Program Lead, previously having come from Public Health as a Behavioral Health Program Manager for a county, overseeing contracts and programs there. And in my county, all of the schools have SUD professionals that work inside the school, and the students are able to access SUD services through the school. And so that there's a bit of prevention, intervention, and treatment that the parents don't have to know about, but they can, that the students are accessing outside of it. So maybe it's just because those services are more available and accessible to a child. Not always, but in those programs, it's for any child up to age 19, and they don't actually have to be attending school at that school. They could be a homeschool student or an alternative school student as long as they live in that district. So that I don't know that that's the reason for the lower numbers, but I am saying it's another off-ramp that they may be accessing.
Hi, this is Michelle. So the SUD, is that strictly SUD or is it co-occurring?
High-level overview generally, when someone gets co-occurring, our system requires a primary diagnosis to be billed under. So if the primary diagnosis is SUD and they're also getting some mental health support around that, it would look like SUD treatment. If their primary diagnosis is mental health, but they're getting SUD support around that, it would look like mental health. So it's very difficult without looking at deep dive data and trusting that all of the diagnoses are entered in all of the systems as they get to us to know. For FIT specifically, I think it's safe to say that the SUD FIT is a primary diagnosis of SUD, could be co-occurring. They do.
Sorry, this is Peggy. I was wondering how I raised my hand, but I would say that with adolescents, it's extremely rare to not have any reason other. I mean, there's going to be a mental health diagnosis. That's part of our challenge in how we view kids. And this part of the system is kind of not super functional for how do children end up having a drug issue when we don't look at other issues that might be undiagnosed around disability, for example.
Do you want to restate your question? Because I think I had a thread, but I don't. Or did that resolve it for you?
Right now, we're looking at co-occurring as a whole for adults. So are we doing that with children? You know, so there's got to be something behind it.
Yes. The goal is for the therapeutic care to meet exactly what the person in front of them needs, whatever array of services that is. There's training lanes that are separate. There's licensing lanes that are separate that make it tricky, same as in the adult system. But for that adolescent or developmentally appropriate age span, it can be, there's I would say the providers out there, there are pockets of brilliance, where they've figured out how to code and how to do the thing and meet the person's needs. And there's pockets where there's a lot to learn, which is a similar answer to Peggy's.
One get to drive their own recovery.
Care should be again, pockets of brilliance, like providers and systems of care that live in communities are unique across the state. And sometimes by the provider that they're connected to and what they can offer and support. Generally, care is supposed to be centered around what that young person's goals are and how to get them there in combination and support of the family. So that whole unit should be part of that. With FIT, sometimes what happens is that the focus initially is on getting that young person engaged, so it looks like help. And then as they're ready, bringing in the family for those conversations that can bring that family back together on a same page to move forward. That's how it should work. And again, training and education, unless someone has a really spectacular mentor or clinical supervisor, you don't really learn how to do that in school. And if you learn about how to do it, you don't learn how to do it. It's a whole unique like cosmosis or universe for each family that is unique and needs to be each person heard all the way through, and then help those connections to be made where there's wounds and fear and the stuff that gets in the way of all families when there's situations that come up that are scary.
Thank you very much. Do we have any other questions?
Now, I have one question that Diana's comments just brought up is the challenge. I think a lot of the kids that fall through the cracks are situations like mine, where we had this, police officer approach to juvenile behavior, and that was not the therapeutic approach that my children needed. And that part of consistency among the adults, we had this additional adult in the equation that is centering things around the youth's goals, but the family goals haven't been really clearly established, and that's part of the reason. So have you considered training for navigating families where there's extreme problems and figuring out how to parent some of these kids? That's all.
So having a kid that has spent 4 years of his life at the Children's Long-Term Inpatient Program, or CLIP, one of the most impactful things for my family in that experience was access to the family therapy. We had experienced so many system-embedded traumas. We had a profound lack of trust with anyone in a professional capacity because my children had been told by a CPS worker that they would be removed from our home if my son harmed any of our other children. So there was a period of time where we had to overcome that as a barrier to the therapeutic process because my kids were like, everything's great. We don't want to tell you anything because we know what will happen. And so finally, through a lot of therapeutic process in Child Study and Treatment Center, we were able to receive dialectical behavior, DBT skills training, which was so impactful because when a kid is learning coping skills and coping strategies to manage their own behavior, the reality is that kids experiencing serious emotional disturbance create traumatic situations for the rest of the family that have to be navigated. Siblings that are afraid, parents that are afraid. And I agree with Peggy in so much as I shouldn't have had to wait till my kid was in CLIP to get those services. We need a preventive approach that attempts to acknowledge what families experience when an individual has a serious emotional disturbance.
quick comment.
The mic cut out.
Hello, there we go. Okay, loud. So I worked for 3 years at a CLIP facility, and one of my complaints, and I'm just curious where this falls in this whole process, was I was the parent advocate there. And when the rubber met the road, there were families we had that just wouldn't engage. And I hate using this word, but I can't think of another one. We had no mechanism for making them engage. So what ended up happening was we were just sending the youth right back into the same home. The family didn't get any help, and often that youth would end up back in the system.
I appreciate all of the comments and feedback and question. Yes to all. I think one of the things that with Patty King's leadership have been working on setting up is the Center of Parent Excellence, which does create the avenue for parents to get connection with people who have lived experience as a parent, trying to figure out the system, and they do a really beautiful job with those connections. So that's one thing that is hopefully growing over time. I think the other thing I would say is I'm looking forward to the strategic plan subgroup of the Children Behavioral Health Work Group, because I think Medicaid and federal dollars can be used for deep end supports and services, but that early intervention and prevention to engaging in deeper end services can be harder to fund, and part of that in Diana's world is there really aren't the right diagnoses for the kinds of trauma that shows up in children earlier on. So to get funding for the things that are showing up that are rooted in trauma can be really challenging because the diagnosis available in the DSM aren't there yet. I think that's a piece of it. So hopefully with state funding at some point in the world, we could stand up some of the earlier work. As far as how to get parents to engage, this is in my heart the challenge I have, not challenge, but I think the opportunity we have with FIT in that we need to make sure providers understand the importance of bringing in family, and they're in our clinical training that folks go through in school to come into the field. It's not really there. I've said this, I'm saying it again. And if you did go through how to do it, you don't learn how to do it unless you have somebody there with you that you can debrief with and figure out how to improve it. There are DBT, I agree, I'm a self-study DBT person, weekends and nights out of my own pocket in order to bring that to the kids that I worked with because the kids I worked with had that funky, complex trauma that doesn't qualify anywhere, and they needed something different than traditional things that are taught in school. And providers need support, recognizing and understanding there are families that won't engage. So there's, and then where that avenue is in, they won't engage, but they will if you give them time and lots of connection and lots of opportunity.
And lots of, again, our barrier was mistrust because we were on the receiving end of abuses by providers. So there needs to be training offered to providers and systems that the language they use matters, that, just like this conversation where we come into a conversation that's pretty uncomfortable, when we set the tone of, I'm going to listen to what you say, even if I disagree with you. I'm going to assume that you mean the best. When you come into a conversation not wanting to hear what a person has to say, you don't have to say that to them because they know by your body language. They can see it when they look at you. And that's how parents are responded to in the systems that we have. We come to a person already totally traumatized, experiencing awful things at home. We're desperate to find resources, and the person we reach out to for help says, well, what are you doing to cause the issues? So it becomes a barrier to wanting to reach out ever again. And we have to retrain systems that language matters, how we approach someone matters. Coming at someone with an assumption of best intent is very important, and that has to be baked into the systems. We have to figure out how to get there.
Rochelle, I wanted to follow up on Diana's comment about diagnoses not being included. So, because that I think is another important part of this issue. Like my son is cognitive disorder NOS. Like, what does that mean? What does he need? Yeah, and he now 24 is starting to establish what is his disability. You know, it's processing, it's being able to be quick, it's memorizing things and keeping them in his head and all, you know. But when people don't know what your diagnosis is, it's really challenging, right? And part of the silos are part of the problem. And because the diagnoses are happening oftentimes in the schools, and there's an opportunity this year where fetal alcohol spectrum disorder, I don't know if that bill to fund additional services passed or not, but I know that they were working to raise the ceiling of the poverty level to provide support to families. The Republicans were bringing that. So I know there's been some attention to FASD. And like 10 to 20% of our children may be fetal alcohol spectrum disorder. And hallmark symptoms of that are high impulsivity and unable to know consequences. I mean, I know Rochelle's son has that issue. And that's part of his challenge, right? And it's part of how do we keep him safe and keep other people safe? And what we've got these adult focused diagnoses that don't include development because we have a system built on adult services like healthcare and DCYF, but then some of these behavioral health related diagnoses are being made in the schools. ADHD, that's a behavioral health. I mean, yes, it's developmental, but how you learn to cope with it affects everything for the rest of your life, right? And if you're punished and shamed, you can develop this whole shame profile that creates massive problems. So maybe we could incorporate in your, you know, it's like DCYF does the FRS WISE program. Why is that over there as opposed to embraced in the whole healthcare authority approach to family health? That, I guess, is a question.
Mm-hmm. Rochelle reminded me of something I just wanted to mention, and I will not use names. So a provider I used to work with many, many years ago, one of my first peer jobs, I was on a wraparound team, and I still remember this meeting I went to. They were talking very bad about the families. And I said something, and they looked at me and they go, you have to realize not all the parents are like you. And I remember saying, well, maybe they would be if they got the proper support. So I say this because I firmly believe this thought process still exists in our system, and we perpetuate it because our system keeps contracting with these same providers that are doing the same thing with the same thought process without ever questioning them or holding them accountable. So.
Any further comments on this subject? Any additional questions that folks would like to ask? And online, you can unmute yourself or indicate in the chat.
Well, my question would be, I brought a whole bunch of opportunities for engagement with community on issues that, you know, I've seen. So what happens next? You know, there is the family initiated treatment improvement. I don't know if it's an improvement process, but they're doing survey as part of the bill that we passed. But there's all these other issues. You know, how do we have a relationship with this, with the groups like this, and part of it is we have so many different groups. So we've got this group, we've got the FISPERTs, we've got the local county ones, and it feels like all these groups, in a way, and accountable communities of health, and they're not connected in any sort of organizational system where they're not sharing information of what their priorities are, what they're working on, what they see what the issues are. So to me, like, you guys, what do you do next? It's really more like, how do you bring this out to all of these? We've got a new ombuds program. What do they think? Like, how do we bring all these voices that are working in different silos and segments? And then maybe that's a strategic planning process, but it's part of, there's a whole bunch of issues on FIT and they're being addressed here, but they could easily be having brought up through the FISPERT system. And that's part of the confusion, I think, within people like me out in the public is, where do you go? Where is your voice heard? Where's the accountability? Where's the buck stop? Who's the one? Like there's so many people working on FIT. I don't know, what Monica does versus what Kimberly does versus what Enos does, what Diana does versus what, there's so, but there's all, again, which of these committees? So where do things rest so the community has a place to bring our voices where we know it's not just me against the healthcare authorities inbox, which is what it's sort of been, which is not a good relationship to have. And Diana and I think, have done a marvelous job of maintaining a friendly relationship through all this because we do both believe. And she's been awesome at accepting me as knowing I'm bringing this because I care, not because like it's personal. It's not personal. It's because I care, right?
I just want to say I recently, again, I just came back from a children's behavioral health summit where we talked a lot about this, about the thing you just mentioned in terms of there being not a central hub. And I know that you are intimately connected with BH360, which does attempt to help with that. In addition, I sit on the Office of Recovery Partnerships board. We had a presenter at our last meeting come and talk about work that's being done toward this end on behalf of adults. And of course, me being me, I'm like, are we gonna do it for kids? And so I know this is being talked about. In addition, I will say the presentation that David gave today has inspired a whole bunch of thoughts in my mind. I really want to lean into figuring out how much money we have, either just from our own planning committee funds and possibly from other sources that we could access to pull together like listening sessions where we have a 1 or 2 day event and we bring people in and we do like our own little summit where we have that chance to connect, ask questions, bring forward issues before you guys are submitting for block grant stuff, so that besides the fact that we're building relationships, so it stops being a us versus them kind of feel in our state, but also there's bi-directional communication going on, and all these different people who have resources and are working on stuff can be invited so that in that process, we're also meeting all the other resources, and it can probably help these several coordination efforts that are happening, but we aren't there yet. Having this place where we can all come together will help those coordinations happen in a more streamlined way.
I would hope that this group would get a presentation or a report from that summit that happened this weekend. Carolyn, you were there, right?
Go ahead, Carolyn.
Yeah, thank you. So one of the things that I absolutely miss that the Behavioral Health Advisory Council used to do was we would actually come together to look at the regional plans of the for the block grants of what our regions were doing and submitting. And that made a huge impact on where our local areas were spending money. And I got to tell you, that made a huge impact on looking at and being more responsive to communities in what their needs are. Because I got to tell you, as much as I go to meetings with several of the folks that are on that and the ASOs and all this, It needs to be more out in the open of what our areas are also funding, because they put them out to the Behavioral Health Advisory Council, which I sit on locally, and we get them and they're already written and they've submitted them and they just want our stamp of approval on them.
Carolyn,
And
and
I don't agree with that.
and in King County, you can't even get a budget of what is being spent on children's mental health because it's out in some sort of wherever. And here's King County, the biggest, it's like the size of a state. And I've been requesting public records to try to figure out what is their plan, what are they spending. They don't have one, I don't think. So yeah, I think that's an excellent idea. I mean, yeah.
I mean, we used to do it, so I really would love to see that come back and hold our communities accountable for the work that's being done, because we're the ones on the ground with our children, with our youth, our young adults. And, you know, it just makes more sense for us to have that look at where is the money going.
Right. And then we could learn from each other too. So I went, and this weekend I was in Yakima and saw the Yakima Children's Village, which is unfreaking believable. It's everything that you would need for a child that has any sort of medical issue, including behavioral health, outside of, you know, surgeries and whatever. It's outpatient services. Their behavioral health units, all of them have proprioceptive, like swings and things, and you know, really large movement, not just little tiny stress balls, but big gross motor movement stuff built into the rooms. This center like has a childcare place when your kids in physical, like all the things I needed. When one of them was in physical therapy, the other one had something to do, so we weren't creating this hostile environment after we left, because both kids, one was exhausted and the other was mad having to wait for their brother. We could have one of those in North Seattle and North King County and South King County. We're looking at family centers, but when we don't talk, like, and then meanwhile, King County's doing some stuff with Best Starts for Kids. Is that working? You know, what are they spending their money on instead of some of these, like, instead of a program like that? We assume all areas are their independent selves, but we need to be thinking more as a larger state, because we are different than other states and we have an opportunity to address things proactively because we really do care, and we have a climate where people want to address homelessness, and children's mental health is the, you know, driver for homelessness for quite a few families or quite a few young adults who don't have the capacity when they leave home to make it in the world. It is really, really hard out there. You know, my 22-year-old is managing to work 25 hours a week, and she lives at home, and on her days off, I mean, she's barely doing anything. Our relationship's improving because she has attachment disorder. So she's developmentally delayed. She's more like 16, but still, like, if I was treating her like a normal 22-year-old and, you know, kicking her out because she's not living up to what I expect of her, she'd be homeless. You know, like, but that we have these expectations that don't match the reality of children.
Yeah, absolutely. Other questions or comments? Go ahead, Crystal.
Yeah, Rochelle, I really like your idea of bringing together the groups into a summit or something like that. And I like what Carolyn was saying too around reviewing the local plans or the regional plans, and maybe that could all come together. Also as an opportunity to bring some providers who have received the funds and talk about, you know, some success stories or something from the block grants, as well as hearing needs and how these funds can be used in the future.
Paul Davis, you're unmuted and you're singing. I guess finding ways to bring together the conversations and then knowing what's going to happen next. So, like, I'd like to know that what I presented about the information sharing, I prioritized that last. I've been knowing that information sharing was problematic in the materials, but I decided I was going to just bring one issue at a time, because 3 years ago when I presented stuff, I just kept getting back, it's all good. And I'm like, no, where in the RCW does it say it's limited to 30 days? Oh, it's not. We can't find it. So now we're, but information sharing, I think I showed very clearly that the RCW is not reflecting what the bill said. And we need to fix that. And I would like to have a sense, Diana, of what the process would be, when I might hear from you, and if they come back and say, oh no, it's accurately, I'd like to know the rationale and be able to have a discussion with that person, because they weren't in the room when we talked about it, right? And not just have a person shit on it because, or whatever they do, but that to me is an unresolved issue that I'd like to not have to keep doing emails over.
Peggy, I'm gonna answer this one. So I want to make it really clear to folks that we've been working with our attorney generals on this. And so, Peggy, am I understanding that you have a disagreement with our attorney generals in the way that they're interpreting the law?
Yes.
Wow. Okay. So let's talk offline.
Wow. Yeah.
No. I thought like, wow, because I think that's as clearly as I've heard you say it before. And I wasn't quite understanding, Peggy, exactly what the concern was. Now that I've heard you say it that clearly, absolutely. I'm more than happy to have attorneys sit down and talk with you about it.
Great, because I think part of it is like, so the 30 days and inpatient treatment, for me, that was also about realizing we don't have any residential treatment in our state. The CLIP facilities are being treated as inpatient facilities. Again, that's the transparency thing. So it didn't matter to the attorneys that it doesn't say there's no limit to inpatient treatment or whatever. It took talking to Kevin Black for the two of us to really understand what I was saying and what the law was saying, and for me to help identify where in the RCW does it say this. These are the things I've been bringing back all this time, is legally focused.
Peggy, I'm gonna ask you one question. What is the response going to be if our attorneys, who are very trained, employed by the state of Washington, and analyze laws for us all the time? We don't interpret the intent of a law, we interpret a law. So if we get word back that this is accurate, what does that do to this conversation?
Then it says, how do we address the gap that was the intent of the committee to have information sharing be a best practice that was proactively encouraged the providers, as opposed to now, like, look at the language, now if, as opposed to encouraged to proactively. Those are like, that's very distinctly different interpretation. And I'd like to know exactly why, and then what the legislature would need to do to address it so it is following what that group of people intended, as opposed to what the lawyers want.
So it's not what lawyers want, Peggy, and we're not going to go down into a huge rabbit hole about this. Lawyers do not want or desire anything. They interpret a law as it's written in front of them in black and white. That's it. Legislatures write intent sections that are not codified into law because they are an intent.
This wasn't in the intent. This was the statement about information sharing in the depth of the RCW.
And what I will say is, Peggy, we will have lawyers look at it one last time.
Okay.
And if the attorney generals who are employed by the state of Washington, who advise us on all of our information, still lead to us having conversations where we don't agree, that is absolutely a time where it is not a healthcare authority or a state agency. We are done at that point. Then the legislature has to take over. So
right,
I think
that's why I've been trying to call a meeting with the governor to talk about this, or to bring it outside of you guys, because it seemed like, but COVID happened. And so it's been really difficult. Half this problem has to do with COVID and people not being able to talk to each other inside conversations and get attention on this. And so yes, I will roll over if they say no, but I would like them to answer the question of, how do you go from it was available before and now you're saying now? That's not accurate. I mean, and so let's just we can talk more and yeah.
We will.
Just
We'll talk offline, Peggy.
legislature.
Absolutely. But I really thank you for just the clarity of, yes, it is that I am thinking this and it is not comporting with what you are being or what you are thinking. That is helpful for me, Peggy, just to hear, I think, black and white, clear, bang, here's the issue. So I thank you for just being really crystal clear with me, Peggy. I needed to hear it and I wasn't picking it up, and thank you. We will continue to work with you and we will continue to provide that information. And if we get to that place where it is what the law says versus what we know the intent was, Peggy, then we will have an opportunity, I think, to figure out where do we go. And
Yes.
that to me is absolutely the legislature. So now that
Yes.
we are starting this, and I know Diana's tried 50 million ways to Sunday to explain it to me, but this is really clear, Peggy, so thank you. We're gonna get this figured out and we'll make sure that we circle back with the attorneys and do all of our due diligence. So
Good.
So
Well,
I think
appreciate
this is a
and I
great
guess I've
note to
always
end
been-
on, because I know I've had the
Yeah.
same situation, and so I love hearing this because Peggy, I've had similar kind of experience, and so this helps even me to understand. So I'm really grateful for that. It is 2 o'clock, so I want to thank Peggy and Diana for your great presentation in this conversation that I hope will continue, because I think it's important. I don't think we have enough conversations here about family care. Go ahead, Peggy.
Well, I just want to make a suggestion for one more topic of conversation in the future is the tension between for young adult mental health and early episode psychosis, which is outside the realm of what I focus on. But how do we help people who brains are not fully developed yet? They just, you know, we know that from the Supreme Court, and the tension between the individual rights and they're not aware that they are schizophrenic. They haven't had the opportunity to learn any skills and deal with this thing that is developmental. It gets tossed on them and then they're treated as you're fully functional. We have to work through the tension of that. And that maybe, you know, at age 25 or 30, we let people fuck up and be homeless and we let them do whatever and we don't care. But we must treat this committee needs to spend some time talking about how do we help the legislature work through those problems proactively. That's what I'm asking you for, Carrie, is like, yes, it is the legislature, not you, but like, what do we say to them when we reach an impasse? Thank you.
Thank you, Peggy. This has been really helpful, really helpful. Thank you.
Awesome. So I think maybe
Thanks,
we'll put that
Michelle.
on. We're going to put that on our list of action items for future meetings as a discussion too for this group to talk about. So thank you guys so much. I want to move on to, we have a new member applicant here, Tessa Clements. Would you want to share a little bit about yourself with the group?
So I have shared a little bit, but I'll put it all together for y'all. So I work for the Administrative Office of the Courts. I am the Behavioral Health Program lead. The Behavioral Health Program inside the Administrative Office of the Courts is a fairly new program. I was the first employee in February of 2022. My role there is really, I consider myself somewhat of a liaison. It's to connect behavioral health programs across the state and in communities to courts so they have a better understanding of what's happening with behavioral health and behavioral health services, and can take kind of a trauma-informed approach to criminal justice. That includes training to our courts, not just judges, but clerks and court admins. And then also my group oversees statewide therapeutic court programs. Washington State has more than 140, which is a lot for one state, and they range from community courts all the way up to superior adult felony drug courts. So we oversee that as well. As I mentioned, I come from a public health background, having worked in public health for 11 years almost before I moved to the court system. So my approach to behavioral health and the criminal legal system is very much a public health approach. I started at the ground there working in maternity support services, moved to coordinating building and coordinating therapeutic courts in Pacific County, and then left having overseen all of the behavioral health programs from prevention to jail reentry.
Me myself. Awesome. So I think that's an amazing addition for us. I move to approve Tessa as a member of the Behavioral Health Advisory Council. Do I have a second? All in favor? Carolyn, if anybody who dissents? All right. Welcome to the ragtag group. Wonderful. All right. So the last thing we have here, so we have a call for volunteers on the membership committee and the bylaw committee. Oh, I don't know if anybody told you, but you have to join one of the committees. So do either of those interest you? Is it good? Okay. Membership? Okay. Thank you. All right, so I know we're going to adjourn here in just a second, but are there any suggestions here for things that we would like to have in the next meeting in July?
I think we need to plan for all the good stuff we're going to put together along the lines of what David talked about, because now a whole new world of possibility has been opened up, and I want to start making plans.
So maybe can the executive team agree that when we meet with leadership next month, that we can sort of lay the foundation for some of this, and then maybe devote quite a bit of time in our meeting in July to discuss how we want to see that roll out?
Yeah, and actually what I'd really like to have happen is in the in-between, before we go to that executive council directors meeting, I'd like to have general membership send over by email any ideas they have. If we're gonna have listening sessions, what should that look like? Who should we invite? What are your ideas for what we do with that time in that space? Please tell us what you think.
Okay.
What about doing some strategic planning? I mean, and this thing kind of falls right into it. Like, what do we want to focus on for the next year? I don't know if that would be possible. It's kind of a thing that's better to do when there's more people present physically.
Yeah, there's that, and I think that we need to really figure out, I mean, we've had a lot of questions about what exactly are we supposed to be doing, where are we supposed to be meeting HCA in the middle, and so I think we got so much great information here. If we could sort of sort that out, then I think the strategic plan could be around that, because right now, to me, I think when I think about what the most important piece of work for us is to strengthen our relationship with DBHR and to make sure that our membership is reflective of the community, right? I think that's really our primary hope. And then beyond that, we want to be doing the work.
And I agree that I also think it would be difficult without having the conversation around if we're going to add a major event like a listening session to our annual calendar, what that will add to the requirements of what we need to do to make that happen. We need to flesh that out before we can plan around it. You know what I mean? So I feel like yes, and I think we should wait till after the July meeting for that.
Anybody else have suggestions of things that they'd like to see, or you want to hear? I don't know who's up next for us in terms of section leads, or if there's anyone that we're thinking about having come in. We have not heard from prevention, and I also think too, and this may depend if the special session that was just called results in a bill, I think there's going to be a lot to discuss there. So that might be something just to sort of put a pin in and see what happens. And then you can check with prevention. I think it has been a while since we've heard from prevention. So do we want to reach out to them, Nathan? Maybe see if they're available, and if they're not, then recovery support services, or really, I think, treatment services. I don't remember last time we've had treatment services present here. That might be a secondary ask if prevention is not available. Okay. Awesome. Hopefully.
So I'm not sure, find out if they're planning on addressing that.
So
They are, you know, 'cause it's all decentralized, all these jails. So, and there's some of them that are in the program, you know, they want to do mental health, continuous care until they get into diversion. But there's some of them that are in silos and they just.
are any of these related to the True Blood settlement that are not receiving their evaluations?
That's kind of it. That's the evaluations, and then there's some individuals that are experiencing mental health and they have medications, but they can't get their medication. They get arrested and they're in jail.
And a lot of what you were just talking about is individual based on jail administration's policies. And like you said, that they're siloed, each jail creates its own policy. Oftentimes, the barrier being who is allowed to come into the jail, and not so much that they're not giving them their medications, because by law they have to. It's an issue, but they're not letting the right person into the jail because they don't have the right background check or what have you. So maybe somebody at the state can talk, that can give us insight into how to make impact on those jail administrations, so that there is more a concentrated effort across the state to continue treatment in the jail.
That would be awesome. Nathan, can you do some research and find out who that might be, unless you already know? Okay, awesome. Thank you. That'd be great. All right, everyone. If you have any other ideas, please feel free to email me or Rochelle, or me and Rochelle, and or Nathan, and we will respond to those then. Thank you very much. I'll call the meeting to a close.